I don't need to tell you that the phones have to be switched off. And anyway, there is no Wi-Fi connection here for all of you. Only for you. We have YouTube live now. We have sent the links to armamentarium, etc. Luckily, the school gave it to us today morning without any charge. And first of all, I'll introduce Dr. Alka Ganesh. We have already introduced her on the group to you, but Dr. Alka Ganesh is an internal medicine MD, would you say? And then chose geriatrics as her area of specialization and was the head of department of internal medicine department at CMC Vellore. Thereafter, she retired from there. Did you practice some time in Coimbatore? 10,
12 years. For 10 years, I was in a hospital called G. Kuppaswamy Naidu Memorial Hospital as a geriatric consultant.
And of course, now she has retired from work since?
2022 I retired.
Okay.
This whole year has been wonderful for all those who have retired and like it.
Okay, she's encouraging retirement, but please don't take that advice and continue your good work that you're doing. We are, as she knows already, we have chosen 2024 to be the year of teaching geriatrics, and I could not find a better person to inaugurate that program than Dr. Alka Ganesh. So big hand to Dr. Alka again. Okay, before we start, may I play a game with the audience? Okay, we'll play the true or false game that we usually play. This is based on geriatrics. True or false will go like this. I'll read out statements. If my statement is correct, you will turn to the right. So everybody will stand in their seats and play the game with us. We do this childish thing, but no. we don't have enough prizes then. When I make a statement, you will have to decide whether it's true or false. If it is true, you turn to the right. So right is right. And if it is false, you turn to the left. And those who answer incorrectly will please sit down, and the rest will play on in the subsequent statements. Dr. Kumar, of course, has created this game. So your questions start now. Iatrogenesis. Iatrogenesis means illnesses that occur due to medical care. True or false? The meaning of iatrogenesis. Medical care. It is true, all of you got that right, thank you. Pelvic floor exercises are useful in stress urinary incontinence. True or false? Pelvic floor exercises are useful in stress urinary incontinence. True or false? It is true. Most of you got that right. Pelvic floor exercises are more useful in urge incontinence than in stress urinary incontinence. True or false? More useful in urge incontinence than in stress urinary incontinence. These terms will be explained to you soon, but it is false. Most of you again got that right. It is false. Asymptomatic pyuria or bacteriuria in the elderly must be treated with antibiotics. True or false? Asymptomatic pyuria must be treated with antibiotics. It is false. Elderly patients with thyrotoxicosis often do not experience classic symptoms like tremors. True or false? Elderly patients with thyrotoxicosis often do not experience tremors. Most of you got that right. True. Thank you. UTI in the elderly can cause incontinence of urine for a short period. UTI in the elderly can be a cause of incontinence. True or false? It is true, that is correct. Osteopenia, as we all know, refers to depletion in bone mass. Sarcopenia refers to depletion in muscle mass. True or false? Sarcopenia. It is true, sarcopenia is depletion in muscle mass. Aerobic exercise is better than resistance training for improving sarcopenia. True or false? Aerobic exercises are better than resistance training for sarcopenia. True or false? Most of you got that correct. It is false. Resistance training is far better. Walking prevents progression of osteopenia. True or false? Walking prevents osteopenia progression. True or false? It is true. That is, most of you again got that right. Muscle relaxants like thiocolchicoside can increase risk of falls in the elderly. True or false? It is true. That is right. I am out of my questions, so you may all please sit down. No prizes to be given. Thank you so much for a big round of applause. Okay, the rest of the information
I
is
don't
being...
think we need this session
We need this
now.
session now?
We don't need, because they also good.
I had reserved only easy questions for them. The rest are for you. Okay. Geriatrics giants is a term used for 5 problems in the geriatric population, and we are discussing those one by one, and then also we'll be, after each giant, we'll be taking questions from the audience. So this will be a more interactive session than we usually have with the audience. The audience, I have a request to make. The audience will ask questions without a mic. I will repeat the question, and then Dr. Alka will say, there will be no counter question from this same member, so that we save time, right? And keep one question per person. So don't say, I have 3 questions, number 1, number 2, number 3, just one question per person, so that we have a more quick round. Geriatrics is a long topic, and we have to finish by 1, because then Narendra Modi ji is waiting for us at home, and we can't disappoint him too. First of all, before we go to the 5 giants, Dr. Alka wanted to say something about why geriatrics is a specialty by itself, and why should you take up geriatrics as your specialty.
Thank you, Dr. Shah.
You can sit and talk also.
You can? Okay. If I get muscle cramps, I'll stand up. Or you are also welcome to stand up if you, or go out if you don't want to listen. Anyway, I was asked these very interesting questions by one of you. I can't make her out. And she said, is geriatrics something like the opposite of pediatrics? I mean, I'm just paraphrasing. So like we reduce the dose for geriatrics for pediatrics, do we do? So my answer to her was, yes and no. It is very different from adult medicine, but not so different. Everybody who's treating adults can tweak their knowledge and tailor it to the aging process. So I think, and whenever I'm asked, do we need MD in geriatrics? Do we need DM in geriatrics? Everybody wants to be a super specialist. I said, no. We want family medicine doctors to know geriatrics. Yes. So when Dr. Tushar Shah called me, I said, wow, this is a nice place for me to evangelize about geriatrics, because general practitioners need to know. Now, what is it that's different? A lot is different. And we can't say it in 10 minutes, because I will be asked to keep quiet. On this side, we have these geriatric giants. So, in a nutshell, if I will say, the aging process, and there are hundreds and thousands of researchers who are looking into the molecular basis of aging. We are not going to talk about that, because they are still theories of aging. But what happens is, we all have to age. There is no 2 ways about it. I mean, those who die early who don't age. You know, the good die young. All of us who are aging may not be that good, whatever it is. But every system in our body ages. And those are deeper points which we need to go into at a later stage. But the main organs which have very great differences. Apart from the obvious ones like skin and hair, which we can see, it is the brain, the heart, the kidney, and the immune system. The liver, GI tract, respiratory if there's disease, yes. But the main things are what I have just stated. And because of that, and what happens is, in each person, different organs age. So one person may have an aged brain. I forgot to say eye and hearing also. One person may have an aged brain, but remarkable kidneys and remarkable cardiovascular system. I'm just trying to draw extreme parallels. It never really happens to that extent. Another person has a very poor heart, but his brain, he can still, if he's a novelist, he can just write novels till his dying breath, last breath. So you can understand immediately the heterogeneity of aging. In a room such as this, I can actually make out there are quite of us who are in the geriatric or look geriatric. But every person is different in terms of which organ has aged. Okay, so that's one heterogeneity issue which we have to understand. So it makes it doubly problematic when you have to treat elderly people. And the researchers, they hate to do research on elderly people because there are so many confounding variables. You take a group of 40 adolescents, all their systems are working almost the same. All the alkaline phosphatase, SGOT, PT, everything is the same. You take an older person, it's all different. So how to take care of those variabilities? So if you notice, people will usually have done studies in from the age of 20 to 50. They shun the elderly. So for a long time, we have not had research on elderly. But now, because in the Western world, almost 15 to 20% of people are in the aged group, they have to do research, and sometimes research is, most of the time research is purely concentrated. So that's one point, the heterogeneity of an older person. And in that, I will just add, so every person has a weak link, every aged person. So the person who's got good brain, poor heart and poor kidney, his weak link is the kidney and the heart. Somebody who's got a poor brain, just the acetylcholine levels are just hovering. You know, acetylcholine is the most important neurotransmitter. It's not the most important, but in the aging process, that's the neurotransmitter that comes down. So if he's got those levels of acetylcholine, I'm just saying it like that, you can't know it, there's no test to know it, but if he's on the verge of dementia or having delirium, he's got a weak brain, whatever insult happens to him, he will manifest it in that weak link. So he will, you do food to him, you give him a little higher dose of a drug, he will go into delirium. Another person whose bladder mechanism is poor, his urge incontinence, you give him, he gets a respiratory infection, he becomes incontinent. He won't cough, he won't have a fever, he just becomes incontinent. So this way, we'll talk about it more in the geriatric giants, you have to be an astute clinician. As I was telling somebody, it's very easy to do DM cardiology, very easy to do DM nephrology, but to be a geriatrician, every case is a detective story because of this possibility. And you can't do a PET scan to find out which is his weak link. You have to do some clinical examination. So that's one thing, let's leave that. The other thing that happens to an older person because of all these changing, aging problems is something called homeostenosis. We've all heard of homeostasis. In physiology, one of the first lectures is Claude Bernard's concept of the milieu interior. Every organ in the body is functioning for one purpose, that is to keep the milieu interior perfect, because we function within a very narrow pH, very narrow oxygen level, very narrow electrolytes. Anything goes this way, that way, we are done for. Even the strongest athlete is done for. So that's because all the organs are working like this. Now, in an older person, very contracted ability to preserve the milieu interior. So that is the second thing that we have to remember is this. So what happens is, the older persons, that question of physiological reserve, as you age, your physiological reserve remains there, but when any insult happens, there's a demand on that physiological reserve as an athlete calls upon that physiological reserve when he's running and doing. Here, just the normal little exercise, he's dipping into his physiological reserve. So there's very little room for compensation. So supposing a lion came into this room, I tell you, all the younger ones will run away fast. All the older ones will take longer to respond because there's less physiological reserve. So the maximal response of any organ is blunted. And the ability to come back to the baseline, time takes longer. You'll come back to the baseline, but it will take longer. So if your heart rate, so if you have to do a treadmill test, most elderly people will not be able to achieve the maximal heart rate, but so we have different stratified heart rates for the aged. Some, because of osteoarthritis, may not be able to do it, but the maximal heart rate cannot be achieved. Once you achieve your own personal heart rate, to come back to normal will take time. So that holds good for every organism. So these are two concepts, if we can take back with us, the two H's, is the heterogeneity of aging in each person, and the homeostenosis is just. So that's one thing that I wanted to talk about. The other thing that I wanted to say, and then I think most of the other points about geriatrics will come out as we speak, as we go through these sessions, is that so often we talk about the biological process of anything, whether it's a young child or we're only interested, most of us, because that's how we are taught, we're interested in lungs, heart, infection, no infection, cancer. So we are dealing with people, forgive me if I'm being condescending, but I was also taught like that the human body is a car. We are car mechanics, not told in such crude ways. But fortunately or unfortunately, the person has got a mind and a soul. So we are body, mind and soul. I think the mind has been very neglected by non-psychiatrists, whereas the psychiatrists only think of the mind. They've forgotten there's a body, okay? So, as in primary care, the mind is as important. You can give the best medication. You know, in Tamil Nadu, we have a saying called kairasi. Only if you write the paracetamol as Calpol, only then my pain will go away. So it's deifying the doctor, okay? And so what is that? That is the faith, that is the mind, and that is that we have to address that. In elderly people, the cognition, the mind becomes very, very important. And then the third thing, the soul. I have kept out of the soul because that is we will leave it to our holy people to deal with the soul. But just be aware there's something called the soul. I think many of you may be more equipped for that. But my plea is that for older people, what I've tried to understand is, it's easy to understand the body, very difficult to understand the mind, but the two are completely interlinked, and we need to think about that. And the social, we are dealing with the medical aspects of aging, but there's a whole new thing about the social aspect of aging, which we can't address immediately today, but that is also very, so things like elder abuse. How do you recognize elder abuse? Most of the time it's not recognized. If it's recognized, we are too fearful of bringing it out. So elder abuse is a very major topic which we should do. Then the last issue that I want to talk about, and then I'll stop, is that though aging is inevitable, we must try to slow the aging process. Not because we want to live longer. We do not know anything about longevity. We are not interested as physicians in making somebody's life longer. I think that is not in our purview. What we want is the quality. The quality of life till the end, whatever that end is, should be as good as possible. And some people have used a very funny phrase for this. I don't think it's a good phrase, but that's the only phrase I have. Compression of misery. Compression of misery, what these people say is, you know, we all know people who had a stroke at the age of 65, and then from 65 to 80, they're limping along. They've got dismobility, they start falling. That's not a good life to have. Our concept of aging must change. We must think of elderly people who may look old, but their functional capacity is perfect, is as good as possible for that age. The functional capacity. So here we come into that area of not just prevention of disease, but promotion of health. And when we say promotion of health, we are slowing the aging process. And now the United Nations has taken this up, the WHO has taken it up as the decade of healthy aging. So we'll talk a little bit about that later on. In this decade, they have started to put out many different methods and promoting how we can slow the aging process so that people remain as healthy as possible for as long as possible before the final end comes. So I just wanted to bring in that concept of healthy aging, which is very important. Thank you.
Thank you. So, thank you, Dr. Ganesh. I think that was a brilliant introduction to a very, very complicated topic, as we can see. We will go on to the 5 geriatric giants. Geriatric giants is a term used for 5 problems that the geriatric population has. And these are 5 I's. In the USA, they use 5 M's, I think. But we will restrict ourselves to 5 I's. I is for incontinence, for iatrogenesis, for instability, for immobility, and for impaired intellect or memory, that is impaired cognition. These are the 5 I's of geriatric giants. Yeah. Cognition includes memory and intellect and maybe speech. The 5 that is in cognition. A classic example of impaired cognition is vascular dementia and Alzheimer disease. Then incontinence, there are multiple forms of incontinence. The commonest forms are stress urinary incontinence. The second form is urge incontinence, which is due to overactive bladder. And the third form is overflow dribbling. So these are the forms of incontinence. There are 5 giants. There's one more. Okay. What have you written? Instability, immobility, iatrogenesis, and these are 5. She says there's a 6th. It's I can't remember. Yeah, that's the first one. Okay. So incontinence, of course, is the 3 times. Instability, when we talk about instability, we talk about diseases like Parkinson's disease or orthopedic conditions like spine, osteoarthritis. Immobility is a patient who is, for example, bedridden and therefore more prone to bed sores, aspiration, etc. And so these are and iatrogenesis is what we encounter a lot because of ourselves. So iatrogenesis is what we do wrong to the patient. Both outdoor and indoor iatrogenesis are possible. So we will take each topic after, she found one more? It's 5, yeah. So we'll take each topic, and after each giant, we will have some question answers for 5-7 minutes, and then go to the next giant. I'll try to place as many questions as are relevant to us, to her first. First of all, Dr. Alka, what age defines geriatrics? In pediatrics, we used to say 12, then the pediatrician wanted till 14, now they wanted 18. Nahin? So what is geriatrics? It's on. That's okay. Yeah, yeah. You'll have to keep the close more.
Yes, so age. That's a very hard question. And because there's no answer, there are 3 or 4 answers. Okay, none of them or some of them may be correct. Multiple choice question. So when I asked this of the senior geriatrician whom I was following in 96, he said, his definition was, any older person who has more than one comorbidity, if he has a comorbidity. So if he's just hypertensive, reasonably anybody can manage. This is talking from the medical perspective. But a 65-year-old who's got 4 comorbidities requires the services of a geriatrician. That he talked from that perspective. But subsequently, people have, because of this very idea that I mentioned of heterogeneity, a 60-year-old may look like a 80-year-old, 80-year-old may function as a 70-year-old. So where do we start? So now some people have tried to do a semi-quantitative thing. They say 65. Now 60 is what the World Health Organization uses as the start of geriatrics. But in many countries, 60 is not considered. In most industrialized countries, it is 65. So this is 65 to 74 is the young old.
The young old.
Young old.
Okay.
75 to 84 is just old. And 85 to centurions is the very old. So some kind of a mild, moderate, severe kind of business. Yeah.
Okay.
And then there are other gradations of it.
What are you in this?
I'm old. Just
old. Yeah. Let's talk about incontinence first, if I may ask you some questions. There are multiple subtypes. What the family physician should be able to recognize, and they already do know, what are the symptoms which tell us what is the subtype. So if you can tell us about how does SUI, stress urinary incontinence, present? And is there anything specific that you would like us to learn about that?
Yes. So incontinence is something which I don't know how many people here think it's a major issue. Do patients come to you saying they're incontinent?
How many of you think, raise your hands, it's a major issue?
As the first problem? One of the problems. They'll come with something else and then say, by the way, this also is there. Whereas if they have very severe incontinence, they won't come to you. They will go to a urologist, okay, or they will go to a gynecologist. But incontinence is very common. Now, if you read how common it is, some people say 40%, some people, and for different types, it's different. So the fact of the matter is that every older person is entitled to be incontinent, okay? And previously we used to say, old age, well, manage it. That is something completely wrong. It is a blasphemy, okay? So it's your business to ask at some point. Now he's come with a headache, don't say, are you incontinent? I'm not saying that. But at some point in the assessment of the person, you have to ask, by the way, do you leak urine? And incontinence definition is, if it's a bother to the patient. If the old lady in the village wearing a sari in a tropical country is leaking 15 ml of urine and is happy with it, she's not incontinent by our clinical definition. It's not a botheration to her because everything is drying up. 5 ml of urine in somebody sitting in a hall wearing a western dress in an air-conditioned hall is absolute disaster. So you understand? So if the person is incontinent by his or her standards, we have to find out the 3 types. There is a 4th which is mixed, and then 5th is functional. But the 3 main clinical types are the stress leak, which already Dr. Shah has talked about, the urge incontinence, and then the overflow. And very easily you can suspect which one it is. A problem happens when there is a mixture of urge and overflow, urge and stress and all that. But let's be simple. Let's just talk about the three. So stress leak almost never happens in a male. A male who has had a surgery or some abnormal urinary tract in the past, yes. But 95% restricted to women. And the very obvious thing is, when there's a pressure in the lower abdomen, small amounts will leak out. So getting up from a low chair, coughing, sneezing, straining at stool, this involuntary leak happens. And if it's a bother, then it's up to you to do something about it. And you can easily diagnose it. If you have a doubt, just make the person stand up or even lying down. You can just part the labia and ask them to cough. And a little spurt will come out. You can keep a gauze or something there to just see whether it's wet and all those kind of things. But the history is more than sufficient. You don't have to ask these questions. And especially if they've had vaginal deliveries, much more common to have is because of prolapse of the bladder below the sling, the levator sling. And so every time there's pressure, the external sphincter opens and urine comes out. So we all know it's pelvic floor issue. The neural mechanism is really intact. So this is the thing where you start with pelvic floor exercises, which are known as Kegels exercises, K-E-G-E-L-S. And we must reassure the patient and tell them that it is very, very vital. It's not just something we are shunning you off. Don't give medication. You can explain it yourself, but it needs constant repetition. So what I do is I tell the patient, then I have physician in the South India, we have a lot of physician assistants. I teach my physician assistant, I say Kegels. So she will teach that person in detail. So basically what you're saying is, hold the urine, contract your perineal muscles as you would do, because we can't show it, you see, as you would do if you were passing urine and had to stop in the middle. But when you say that, please be careful, because then they will, when they're passing urine, they will try to do it. Never do it when you're passing urine. That's very bad, because you might get reflux. So just to say which muscle to contract, you say, that's the muscle. So they have to do this 10 times, at least. And the best position, they say, is lying down. But you can do it anywhere. Sitting down, you're going in a lift, anything. Just do it 10 times, minimum 3 times a day. Now, how soon can we see the result? It takes 3 months. But the result is very good. But it may not be good. That is, so once you've given a trial of Kegels, and the leak is not that problematic, they may just keep on doing that. If it doesn't work, then they have to have either a gynecological referral or a urological referral, where they do, previously they used to do colposuspension and all those horrible surgeries. Now there's a daycare surgery, which I think the urologists are better at, and I'm not just saying this because my husband is a urologist, but now there are what do you call them? Urological gynecologists. Yeah, so they can do this TVT, tension something tape. And I don't know, you have experience with that? Some of your patients have had. It's supposed to be quite good. So it just hitches up the bladder neck and gives a very nice mechanical kind of angle so that they don't leak. So stress leak is that. So briefly, I've spent a lot of time on stress. Let's talk about urge. Urge incontinence, common to both sexes, happens to every aging person. In some people, it goes to the extent of actual incontinence. But urgency is a normal aging mechanism. And I think you all know why. Okay, just briefly, we know that the micturition cycle happens in the via the autonomic system, the parasympathetics from the sacral cord outflow, which causes contraction of the detrusor muscle, and opening of the internal sphincter is via the sympathetics, which come from the lumbar outflow. So that is sort of okay. That is a problem there, some problem there. But the main problem is in the cortex. Now the higher centers also control this reflex arc of micturition, which is as soon as the bladder muscle stretches, the reflex arc is activated, detrusor contracts, sympathetics open, internal sphincter opens. But that happens with 200 to 300 ml of urine. But we don't want to pass urine every time there's 200. So the cortex says, stop the detrusor, and again the cycle happens. Till it reaches a point where you must go, or there's convenient to go and then you go. So what is this higher center? There are main centers are in the pons, but overridden by the cortex. There are inhibitory fibers coming from above, below, and there are facilitatory fibers also from above, below. So we can pass urine at will even if we don't need to. We can stop the flow of urine when we have to, when it's not convenient. Now what happens as we age is that the inhibitory fibers deteriorate much more than the facilitatory fibers. So we can't stop. The moment the bladder starts screaming or just whispering, we better go then. Otherwise, incontinence. So that's urge incontinence. And this is something which is common, equal to both sexes, easy with drugs to use. So, you know, anti-muscarinic agents, anti-parasympathomimetic agents are what we use. And these are very finely tuned, not perfectly finely tuned, to only affect the muscarinic receptors in the bladder. But, you know, like atropine is the worst one. It affects the heart, it affects the brain, everything, including the bladder. But these muscarinic, anti-muscarinic drugs affect predominantly the detrusor muscle. So its main action is there, but a little bit of dry mouth, little bit of cardiac effect, etc., will be there. So these are all your toltridine and all those drugs, newer ones also are there. So that's urge incontinence. And then there are others, sympathomimetic agents. I don't think we'll spend too much time on that. The third type is the overflow incontinence, where there's an obstruction to the flow of urine. The most common one we see is the prostate enlargement. And then it could be a urethral stricture also. So what happens is the bladder is never emptying completely. When the person wants to void, they will void. They can pass urine with difficulty, the stream will be poor, but there'll always be a post-void residue. As soon as the intravesical pressure falls below the urethral pressure, they will stop. The bladder won't contract, and there'll be a residue. So up to 50 ml of post-void, which you can easily check in an ultrasound, it's fine. But when it becomes 75, 100, 200, 300, then you've got, what happens then is, as the amount increases, the intravesical pressure goes up and urine will leak out. That is well known as, easy to imagine as, overflow incontinence. How will you detect it? One is male. Females don't have that much because urethra is short, there's nothing obstructing it. So a male, when he says we have to, and he could have a mixed. So how do you diagnose that? Ask him to pass urine. Easiest is ultrasound, but in your clinic, ask him to pass urine, palpate for the bladder. Easier said than done, because if it's an obese person, you can't. Percussion isn't always very good. But I think I always go through that process. Even if I know, because somewhere I'll strike gold. It's a thin person, you see a bladder, I will know immediately it's an overflow incontinence. That one has to go to a urologist. It's out of your hands. Then there's functional incontinence. Functional incontinence is, he's got incontinence, maybe a bit of any of those, but he could go to the toilet, but he's got bad knees. He can't go in time. That's very easy to treat. How will you treat somebody with functional incompetence and bad knees, short of doing a knee replacement? Absolutely. Just bring the toilet to if the mountain won't go to Muhammad. You'll have to bring Muhammad to the mountain, or whichever way it is. So that's functional incontinence. So as a geriatrician, you can do many, not as a geriatrician, as a family doctor, you can do many things for incontinence and appropriate referral drugs.
We'll take a couple of questions. You can raise your hands. I will repeat the question for the audience. Dr. Kumar?
Sorry?
For pharmacotherapy of stress urinary incontinence, duloxetine has been probably approved. Do you have any experience?
No, I've heard of use of duloxetine, but I've never used it. And I think if you have experience on it, you can share that. I don't think it's very useful.
No.
Is it not useful?
There are other better modalities. Any other question on incontinence? Yes, Dr. Sheila? The question is, what will be the symptom of the patient in urge incontinence?
Okay, yes, sorry, I did not mention that. So in urge incontinence, the person will say, I have to go when I have to go. Otherwise, it's a disaster. They must go the moment they feel they have to go. So I have a friend of mine, we were on a tour overseas, and whenever we went to a place, he said, first identify the toilet. So he knows it's there, and he can run immediately. So, because he's got urgency, okay? So, and then the amount that is leaked out, it will not be small like a stress leak. It will be at least, but not so huge. It'll be at least 100 ml. So it's quite a difficult problem, issue. And then to substantiate that, you must need to do a bladder diary. A bladder diary is very good even in a patient who has nocturia, passing urine at night. But in this, what you're just trying to prove is what you've already got in the history. So you ask him, but people don't like doing it, facilitate it. Tell him how it's easy to do. He just has to do it for 2 days. Please help me. This will help you, the treatment and all that. But nobody wants to collect the urine, measure it and all that. But basically, every void has to be how much quantity, what time. So then you find out if it's frequent, every 1 hour, passing 100 to 150 ml. So we know such a small volume coming in is making the detrusor very, very irritable. Cannot control it. So he's got urgent incontinence. So it sounds very simple, but when there is an overflow attached to it, an obstruction, it becomes a little bit more complicated, but this is the thing, and it works in majority of the patients.
We'll go to the next eye. The eye that we're taking now is iatrogenesis. Iatrogenesis is problems induced by medical therapy. In the elderly, if I were to ask you, what is the most common iatrogenic problem that you see? Or maybe most 3 common, what would you say?
Of course, the most common is drugs. Because so many drugs interact, so many elderly people cannot tolerate certain drugs, whether they are NSAIDs or antibiotics or aminoglycosides, because of the aging process. So because of the aging process or because of the other drugs and the comorbidities that they have, certainly prescriptions, inappropriate prescription is the most common. Number 2, the thing that can happen is hospitalization. So you may say, so if a person is sick, we don't admit to hospital? Well, the concept is coming like that. Try to treat the older person as far as possible outside the hospital. So that brings a very big burden on general practitioners, outpatient management. I'm not saying we're ready for it, but if you admit the patient in hospital, what happens is it's proved functional decline. When he went in, he was able to climb the steps. When he came out, no more. Even when he gets over the disease, he can't climb. Why? His muscles have gone for a 6. Inactivity, say after a hip fracture or anything, muscles have gone, it takes months to recover. Number 2, by hospitalization, nosocomial infections, very common. And number 3, pressure sores, very common. It takes just 48 hours to produce a pressure sore in an aging skin. So these are the 3 main things for hospitalization. And we put it as iatrogenesis. This one.
As manifestations of drug, adverse reactions. One of the reactions are hyponatremia and altered sensorium in the elderly. And all of us have seen hyponatremia very commonly with thiazide drugs or psychiatric drugs. How should the family physician suspect hyponatremia as a problem in a person at home?
Yes, so almost every drug I think causes hyponatremia, even NSAIDs. As you mentioned, most of the psychiatric drugs, especially the antidepressants, and later we'll see that they do need antidepressants, and they cause hyponatremia. So almost any drug can cause, except for paracetamol and antacids, I think. But if you've added a new drug to a patient, he could go into delirium. And one of the causes of delirium would be hyponatremia. So when hyponatremia occurs, it affects the brain because the brain is aging. So they may be asymptomatic hyponatremia. Say the sodium is 128 and they are quite okay. But for some reason you just checked the electrolyte. I don't know what would be the reason, but you just checked it. You might find 128 and he's okay. So asymptomatic hyponatremia probably goes undetected. And there's no real reason to detect it either because we would not treat actively. And if it remains like that, it's all right. But the asymptomatic may have a chance of becoming symptomatic. So what are the symptoms? It's mainly cognition. So they will go into delirium. And delirium is a very big topic in itself. I don't know whether we will deal with it. Just give you overviews. The person's behavior changes. It could change, and how do we say he's being stubborn, okay? Doesn't want to move, he's not getting up, he's not going for his bath, or he may start talking too much, may get agitated, so you can have an agitated delirium. You could have the opposite, quiet delirium. He may just go to sleep and do not want to get up. Or inattention. You're talking to him something and he's answering something else. He's not focusing. So when you notice a change in the patient's behavior, it may be very subtle. Very often, even I have missed a case, so many cases of delirium, and later we said, oh my God, he was delirious even then. So delirium is the most important. And then of course the worst example of hyponatremia is coma and then seizures. So anybody coming with seizures, we would definitely check the sodium. Then it's too late actually. I mean, then you have to quickly replenish. You can't actually also if sodium has come to 100, you suddenly want to bring it to 140, you know what will happen. There's an osmotic disequilibrium, nerve cells swell up, and he gets a pontine damage. He can become quadriplegic. So there's a prescribed limit, only 10 to 12 milliequivalents of rise per 24 hours. So that's the extreme end I'm talking. So any seizure patient going in, you will obviously be sending into the hospital. Sodium may be one of the causes. But our duty is to recognize that early stage of hyponatremia and then how to correct it.
Your experience with drugs like tolvaptan, SIDH, etc.
Yeah. So tolvaptan really is working at the renal level, and it's preventing the action of vasopressin, ADH. Because what happens in hyponatremia is, most often, is the total amount of sodium in the body is actually okay. There's just too much water in the vascular system, so it becomes dilutional. So we used to call it as dilutional hyponatremia, as against depletional. So this is very funny balance in an older person between the ADH. There's always a little too much overactivity of the antidiuretic hormone. It's slightly more at a lower osmolarity, it will start function at a higher osmolarity. It will start functioning and try to dilute the urine. Okay, it will retain free water. So, on the other hand, the kidney tubules not able to concentrate. So they are leaking sodium also. So it's a little difficult to understand, but when you have hyponatremia, we have to identify the SIADH, syndrome of inappropriate ADH secretion, which is different from depletional. So what do we mean by all these terms? So depletional is when somebody is having diarrhea, vomiting, all those things. The urine sodium will be very low, kidney is concentrating. Then we have the hyponatremia where the person has got cirrhosis, cardiac failure, the whole works, and they are got low sodium, and the osmolarity of the blood also may be low. Whereas when we talk about hyponatremia, most of the time we are talking about normovolemic. The person has no edema, the person's skin turgor is fine, is normovolemic, hypoosmolar. If you can calculate hypoosmolarity, we don't have to bother about that now. By electrolytes, you can just multiply sodium and this and that. And you can find out that the osmolarity is below 270, okay? 270 to about 310 is normal. So a person who has got the hyponatremia due to these drugs is mainly is a SIADH type. He's neither losing sodium in diarrhea and all those things, he's neither retaining water and sodium in heart failure. He's got a little bit of SIADH. So how do you treat that? Asymptomatic person, you just found out he's got 128, find out which drug you have given does that, take it away if you can, and then ask him to restrict water intake to, Western literature says 800 ml. In a tropical country, 1000 ml. So that includes rasam, tea, everything. All liquids are 1 liter. So you restrict. And therefore, the hypoosmolarity will then become normal. But for many people, and there are various grades of the thing, we don't need to go into that. When they come into hospital, when they're between this and this, you do this. So severe grades, you need 3% saline infusion, small doses. We don't give 500 ml of normal saline because there you're giving so much of volume. You don't want volume. Already volume is expanded, intravascular volume. So give concentrated sodium in 100 ml, 3% sodium, and check. So now because of this new drug, the trade name is Narsee, maybe others also, if you give it, then ADH action on the kidney is stopped, and you can, it's a very remarkable drug. I find it's just so exciting drug to be given. So exciting drugs we overuse, okay? So when anybody has hyponatremia, just give some Narsee. That's wrong. You have to go through the painful process of first restricting fluids, doesn't work. But if it's very severe, you can start it off immediately. And then you give, I think it's 7.5 milligrams BD, maximum 15 milligrams, and must not give it for more than 15 days. So in your practice, are you going to be checking all this osmolarity and all? If it's possible, please do it. If it's not possible and you're pretty sure it is isovolemic hyponatremia, then do this. Doesn't work for a day, give Narsee. When you're giving Narsee, don't restrict sodium. Don't restrict the water intake. They should be allowed to freely take water at that time. So this is the way that we treat, but hyponatremia is one of the most major diseases which should be quickly picked up. And you mentioned thiazides. May I ask why?
We all experience hyponatremia due to thiazides, where thiazides cause more sodium loss than water loss, as against furosemide, which would cause similar. So thiazides have become, and what has happened is, at least in our observation is, that 12.5 milligram chlorothalidone is promoted significantly as a combination with other drugs. And I think 12.5 is a dose enough to cause hyponatremia of chlorothalidone, which is equal to 25 hydrochlorothiazide. What is your experience with thiazides?
Chlorothalidone is 6 milligrams.
6.25
hydrochlorothiazide is 12.5.
12.5.
So I'm actually one of those people who's biased for hydrochlorothiazide and he's against it. Because the earlier trials had all shown that it was the best drug for elderly hypertension.
Yeah.
because they have low renin hypertension, and this is supposed to, diuretic supposed to increase and all that. So, and then they said it can cause hyponatremia. But I have not found, though we should be getting, because you've got tropical country, people outside, you should be sweating and all that. So, I don't know. My opinion, I have heard many people espouse this view. I haven't actually seen, have you seen any control trials? Have you done? No, any trials at least on hyponatremia?
I don't think there are trials comparing hydrochlorothiazide to chlorothalidone or one dose of HCTZ to another dose. I don't know. Let me take a show of hand. How many of you have seen thiazide-induced hyponatremia?
At least 30%?
Yeah.
I've seen, yeah.
So, yeah,
but would you then not give thiazides to any older people, to all older people?
how many of you think that thiazides are a good drug for hypertension control in the elderly? First choice or at least second choice? Good drug. Low doses, okay.
So yes, so I think that's a good balance to take. Give the drug, be aware of the possibility. What I'm trying to say is, don't throw the baby out with the bathwater. It's a good drug. So just because it causes hyponatremia in some people, don't throw it out, but be aware, that's all. Hypokalemia I have seen even less commonly, but when there are other things causing hypokalemia, then this may exacerbate. But by and large, I think it's a good drug.
Just to repeat something that she said, because hyponatremia due to SIADH is the mechanism by which psychiatric drugs and NSAIDs cause low sodium. Very important to know. So low sodium due to NSAIDs, psychiatric is via SIADH. So in these patients, the first step is of course to withdraw the drug, culprit drug. Second is to restrict fluids, and only the third step would be to give tolvaptan. So we'll go to the next area of iatrogenesis. What important iatrogenicity is in outpatient is constipation. What are the various things that you can tell the audience about being aware of that as a side effect?
The most obvious, of course, is pain medications. Not your NSAIDs, but any narcotic analgesic that you give. Now, I understand that tramadol is combined with paracetamol, Ultracet. And so I hate drug company. I think your group also has been brainwashed not to use fixed drug combinations, because then you forget what are the constituents. So if a person is having such severe pain, it's paracetamol, and then you can add a tramadol so that you know what dose you're giving. But very often what happens is the dose exceeds because the second practitioner does not know that the guy is on Ultracet and gives full dose of paracetamol. So if you are giving any type of opioid, we are only restricted to few opioids. You must give a laxative. You must not wait for the person to get bunged up. So tell them, please keep this with you. If you can't pass motion, you must take it. So prevent constipation. And of course, the stronger ones was the use in chemotherapy. It is part and parcel of their thing to give it. The other thing is hypothyroidism, but I can't, I'm at a loss for constipation as iatrogenesis. What else?
Calcium, for example. Would you say calcium causes constipation?
At what dose? Because calcium we can't give more than 500 milligrams. Can cause.
I would say it can, but and other drugs like those that have anticholinergic effects.
Anticholinergic, if you give, but then we are saying don't give anticholinergic. So if your anticholinergic is causing constipation, then you're doing.
But some diseases like urge incontinence demand anticholinergics as a treatment.
Urge incontinence or fecal incontinence.
Overactive bladder.
Yes. But they never go to I've never seen them going to constipation because you require a very hefty dose of an antimuscarinic. And these, as I just was mentioning, they're very specific for the receptors in the bladder. So they can get dry mouth, they can go into delirium, and they can get a bit of tachycardia, but I haven't come across
much constipation.
Yeah. Hypothyroidism, yes. That's not a drug.
That's not iatrogenesis, okay. Another is infection, iatrogenicity as a secondary bacterial infection because of either misuse, overuse of antibiotics or intravenous antibiotics in the hospital. My question here is, do you see a lot of Clostridium difficile associated diarrhea in discharged patients? Because discharged patients will be seen by them and they should be able to recognize. Do you see them?
Yes, the Clostridium difficile, because we can't test for, now maybe you can test for the toxin, but it's a very costly test, I think 2000 or something like that. But we always suspect that Clostridium difficile is there the moment a person is having an antibiotic and gets diarrhea. So antibiotic associated diarrhea, because we can't check it, we just say antibiotic associated diarrhea. And I think everybody knows that ampicillin, amoxicillin is the most, clavulinate is the most regular culprit for that. So yes, so diarrhea due to antibiotics. And as soon as what I was doing in a hospital-based practice where you give a very high doses of all the, third generation cephalosporins, and now elderly people, you only start with cefoperazone sulbactam, start with piperacillin tazobactam, so because they come in sepsis. Why do they come in sepsis so often? Because the infection wasn't treated properly by the general practitioner.
Yeah, she has this very different view on antibiotic therapy in the outpatient, in the elderly. Will you elaborate on that?
Yes, my view is that when an older person gets fever, it is already too late for the infection. Elderly people who have an infection, now I'm presuming it's bacterial infection, they could very well have a viral, but when they have fever, it's too much advanced. That infection has already advanced, because at a subclinical stage of the infection itself, the person will have other symptoms. They might get one of the geriatric giants. So they may start falling when they have a lung infection without coughing. That's why I say you have to be an astute clinician. A chap who fell without any wires and all over there, he was just okay and he fell, he might be having a respiratory infection, And I've seen it because I've asked somebody who was going for his hip fracture and found that when we took the X-ray pre-op itself, there was a patch. And asked the history afterwards, yes, I was coughing and I had a fever for one day and then I fell down, fractured my hip. So it was the infection which made him fall down, you see. So the infection can manifest in any of the 5 eyes, not the iatrogenesis, of course, the others. So the dictum is, for me, start antibiotic early for an older person who's got fever. If they've got acute incontinence, not a chronic incontinence like what we talked about, suddenly became incontinent, you might be having either a urinary tract infection, but if the urine is clear, then it could be a respiratory infection or some other infection or something. So I'm not saying jump the gun, but be more ready to start an antibiotic in anybody who has fever, who's an older person, especially if they're frail, especially if they're diabetic. Diabetic, there's no question about it there. So that was what we were talking.
So again, I'll recapitulate. Younger people, they come with acute fever, you don't start antibiotic on day 1, you pursue a diagnosis. What she says is, if an older person who does not have an obvious viral infection like say dengue, an older person who comes to you, which may have bacterial, the person before having fever already has the sepsis going on inside the body for a few days before the fever manifestation, because fever manifestation comes late in the elderly because their immune response is that way. So have a high index of suspicion for bacterial infections and therefore start antibiotics quickly. Sorry?
Depending, if you think it's a respiratory, then it has to be a penicillin type, amoxiclavulinate, with, if it's community acquired, macrolide. Of the macrolides, azithro is much better than clarithrol because it has some interactions with your atorvastatin. But if it's just if it's a COPD patient, both drugs. If it's a person with a normal immune system, then we can just, normal older with normal lungs, just amoxicillin clavulinate is the best, or second or first generation cephalosporin oral. Cephalosporins are one of the most benign, favored drugs for the elderly. Cephalosporins. I like cephalosporins for the elderly. Of course, they also cause antibiotic-associated diarrhea, but not so much as the others. And what we do in a hospital-based medicine is the moment the patient gets diarrhea and he needs the antibiotic, we just add, of course, we always try to give a probiotic with the antibiotic. You don't have to give it for everybody in the outpatient, but if you know that that person previously was developing, give a probiotic. I use one called Econom. That's because I can only remember one probiotic. I can't remember the others. Even that I have difficulty. And then if they have diarrhea, can stop the antibiotic, stop it. If you can't stop it, give metronidazole. Metronidazole is fairly well tolerated even in renal. So if it's bad, of course, then you have to admit and talk about vancomycin and other things. That's real Clostridium difficile, but yeah. Oh yes, yes. Sepsis can. Yeah, you're right. Yeah.
Any infection can cause SIADH related
And
hyponatremia
sepsis, yeah.
or dehydration related hyponatremia. Both can happen in infection. Okay, one important concept that she said, and something that involves family physicians, is the concept of hospital at home. Hospital at home is something that we must get more and more familiar with. We already know, you already have patients who are being treated, they have a Fowler bed, they have an oxygen concentrator, they have a suction machine maybe, etc. at home. And this has to increase. And hospital at home, as she said, involves a multidisciplinary approach. So just by you going as a family physician and doing things, maybe you will have to create a team. What kind of team should they create?
So hospital at home is now, we've always had it here in some form, but in the West it is now a new concept, partly because of their remuneration. How do you get insurance? How does you allow insurance to pay for hospital at home? They say they're not in hospital. Anyway, that part aside. The true definition of hospital at home, and I say true because we're all dictated by what comes out of America, their definition is that it will be, the patient will have a doctor's services at least once a day, in person. Once a day in person, with technology multiple times a day through online. Nurse also, at least once, like a hospital visit. So are you going to wait for the hospital team to come? No. It's more, those who are doing it have a community-based team where 10 people are in the roster, you have to travel to each house and look at them. But throughout the day, online should be, at least a nurse should be available. And if any diagnosis has to be done, should be available at the home or may have to go, say for ultrasound or something. So the idea is you're trying to replicate hospital services, but in the patient's home, so that you don't have all the downside of hospitalization that we talked about. But having said that, we know that it's impossible for all people. Now, chronic illnesses, as you said, many people are having, like COPD, oxygen, home oxygen, that's not hospital at home. Fowler bed, that's not hospital at home. That's just long-term care at home. So some patients absolutely cannot have hospital at home. That is, if on oxygen, they're still desaturating. If they're on oxygen saturating, they could still be at home. Any hemodynamic instability, obviously, cannot be at home. But, and of course, if there's an acute stroke, acute coronary syndrome, because acute coronary syndrome is one thing which is very good outcome of treatment even in an older person. So such patients who are rapidly evolving and you think it's acute coronary, certainly no hospital treatment, no at-home treatment. But, so what are the kinds of things? It's not just the ability to go and give injections in the house. That's not hospital at home. That's just home care. But somebody who needs that doctor and nurse to visit, that. So things like septicemia, if they are hemodynamically stable, they could have, you could have that early stage of sepsis. You can give IV fluids, you can monitor it, you can give the IV medication, teams come in and do all that. something like deep vein thrombosis, very common in the elderly. And now, even heparin, subcutaneous heparin can manage. I have managed several patients in the house with deep vein thrombosis, and they haven't gone into, but if they do throw an embolus in spite of that, that's unlikely once you've started the treatment. Then of course they have PE, has to be hospitalized. So basically it's infections, deep vein thrombosis, and then acute exacerbation of COPD also can be, because you can do a non-invasive ventilation in the house. But if they need invasive ventilation, you have to admit them. So these are the kind of things people have been looking at as true hospital at home, and thereby try to make sure that the beds are not clogged up with all these old people who take longer time to recover, and then they get bad in the bargain themselves.
You know of these organizations?
Hello. Welcome.
No problem, no problem. You can please, you can please carry on, no problem. Welcome. Hospital at home, many of you have heard of organizations. Hospitals also, in fact, Nanavati Hospital will do a hospital at home management, etc. Most of these organizations that do hospital home do not involve a family physician. Am I wrong, or is that right? Yeah, now what I would request, if you have patients who require hospital at home and you want to take services from an organization that provides everything, nurse coming in, everyday RMO coming in, you should be actively involved in taking care, because the patient requires you more than they require an unknown or stranger doctor. And you must take care. And I think it's something that we can train ourselves to do fairly easily, because of your experience. You can do this fairly, but get involved. And what will happen, as she said, is if we start sending every elderly patient to hospital for pneumonia or pyelonephritis, which is not very severe with no hemodynamic instability, we are causing more damage than we are taking care of. So we must learn to say no, don't get hospitalized, even though you have a pyelonephritis, because it is mild and we can manage at home. And then you get involved with somebody who will do parenteral therapy, etc. at home.
I fully agree with you, but it is a responsibility to have the team.
Yeah, the team is necessary.
Make sure that there's no weak link over there.
Yeah, the team is necessary. So you find out the team that are in your area, provide services like this, and then get involved on a daily basis. You will also have to visit every day.
No, and I'm thinking that as a future thing, though we usually they talk about hospitalists, but there are one or two doctors who have written personal accounts. They got fed up with hospital medicine, so they decided they're just going to do home visiting. Say, there's a gastroenterologist in the US. He says it's so much nicer to go and visit all these old people. He learned some geriatrics, and he was seeing them in their houses, both as just visits because they were too old to come to the daycare center, and because they needed services of a doctor. So why can't a family doctor be trained, who's got a little bit more idea about geriatrics, be the doctor who goes to visit? Why a hospital doctor? You can be the doctor.
So yeah, I would like you to think about this as how you can do home care for even patients who may require hospitalization, and come up with a structure. And if you can come up with a structure, let us together build something that might become hospital at home as in structured organization. Okay, we'll move from iatrogenesis.
Drug of choice for UTI.
In the elderly.
It's no different from younger. Whatever you're doing in younger. Nowadays, people are giving phosphomycin as the first drug, single dose. It's 3 grams, I think, 300 rupees. But what do you think about it?
She's very cost sensitive, yeah. So she'll mention that every time, yeah. But yeah, so phosphomycin, of course, is for a lower UTI, typically approved in the US only for females with uncomplicated cystitis, not approved for males at all, in fact. And you can, no male, it's not approved for males.
I didn't know that.
So yeah, Dr. Lopa, I'll repeat the question. Okay, she's asking if an antibiotic associated diarrhea happens to the elderly at home, what should be the metronidazole dose and for how many days?
The same, 400 milligrams TDS. Yeah, they tolerate metronidazole.
Maybe 5 to 7 days?
Yeah,
5 days,
5
yeah. Any more? Yeah.
But please prime them with probiotics. At least I believe in probiotics for this one condition.
I'll just repeat the question. She's saying that metronidazole has drug interactions with cardiac drugs. And is that a problem? And I think warfarin is what she might be referring.
Warfarin, alcohol. They're taking alcohol.
Yeah.
They can get.
Alcohol is a good cardiac drug. At least I think so.
But which drug are you thinking of? Which drug are you thinking of?
Basically, she might be thinking of amiodarone and warfarin,
Amiodarone.
as they have drug interactions.
Warfarin, okay. Yes, yes. But warfarin, how much is the use of warfarin now? Of course, if your patient can't afford and needs anticoagulant, you have to give warfarin, because the newer drugs are 5,000 rupees a month or something like that. But yes, I think they are quite all right with, but not everybody is on warfarin.
We're going to, sorry. I'll answer that. Metronidazole drug interaction with beta blockers probably not there. With you said with antiplatelets, probably not there, but we will revise. I mean, might be forgetting, but I don't think there is.
I'm not aware of antiplatelet.
We'll go to the third eye. We are at 10:30. We are working on time. I will request Kumar to just check if tea will be served at 11 with the canteen whenever you can. The third is instability. How do you define instability? Which diseases cause instability?
Instability is just a big word. What we're meaning is falls.
Falls, yeah.
Falls, okay. So elderly people, falls is the other big thing that they sort of fall into the grave, you know. One fall is a step into the grave. So we have to identify the risk of fall. Don't wait for the person to fall. Who is the one at risk for fall? And tackle them and make sure that all the things which are likely to give falls should be taken out. And assess every old patient, even if he looks like a fit Amir Khan or whatever, just suspect his musculoskeletal stability. And that is where at some point we have to talk about the comprehensive geriatric assessment, which general practitioner is well placed to do. So you have to test their stability. How to test it? That means there are many tests, okay? I'll just tell you one that I do, and that is get up and go test. The get up and go test is you make the chap sit down here 10 feet. You put a barrier. Ask your nurse or somebody to make him walk from there to there, turn around and come back, and time him. There's a timed get up and go test. And sit down again. So if it's anything more than 10 seconds to do that, okay, some of them will try to run and do all kinds of things. Just tell them at your normal pace, do it. And if it's more than that, you have identified that this person is slow. There may be so many causes for it, but he's slow. This is like a screening test, okay. And there are other tests also. I don't know whether I should go into all of that, you know, it's the chair rise test. You can just look it up, chair rise test. So these are all screening tests which, or anybody in the history who has fallen in the last 6 months more than once. So these are actually questions which have to be put to everybody. You can't do it in a 5-minute, 10-minute consultation. So there has to be a separate mechanism by which every patient has to have a database surveillance thing with, this is known as comprehensive geriatric assessment. So you ask these questions, screening tests. If he's fallen twice, or this is his second fall in 6 months, immediately he has to have the full assessment. So there is a battery of tests to be done. So any older person with no comorbidities can have a risk for fall, okay, because of poor musculoskeletal deconditionings. It may be the extreme of sarcopenia and frailty, or it may be just another person who's never exercised, just sits and watch TV, okay, maybe 75 years old, maybe very unstable. Then of course there are all the diseases, say neuropathy. So many diabetics are there. They may not complain of paresthesia, but they may have. Very often they have the subjective symptom of neuropathy. Objectively you can't. Whatever it is, if they have got neuropathy, subjective or objective, they are likely to fall. They are high faller risk. So then of course, people can fall because of syncope. So syncope is another very big thing in an elderly person. How do you make the moment a person falls and they come, you have to identify conscious collapse, unconscious collapse. So the conscious collapse is a person who knows that he fell. He can tell you, I went to the bathroom, I fell, and after some time somebody helped me up. And unconscious collapse is somebody who's got cardio-neuro problem. So usually it's cardio. He's got either complete heart block, or he's got arrhythmias, he's got aortic stenosis. Somehow the cerebral perfusion was low and he had a syncope. He will not know how he fell. So he said, I just found myself on the floor. There you must examine because that person doesn't come into our falls category for the geriatrician. That person is persona non grata. He must go to somebody else. Please get out of my clinic. Go to the specialist who can prevent your syncopal attacks, because you are at grave danger of dying. So aortic stenosis, auscultation will reveal most of them, but we all know that innocent systolic murmur due to sclerosis of the aortic valve is very common. Every second patient, if you care to listen, has got a systolic murmur. But it's not aortic stenosis. So how do you make out? Nowadays, I don't know how many people are good at auscultation. In hospital practice, because we have to teach our juniors, we are very good at it. So the second sound will be loud in sclerosis. It will be soft in a stenosis. The murmur will not be conducted to the carotid in a sclerosis. It will be conducted and of course if it's very severe, then of course you will have this pulse, slow volume pulse, most of the time you don't. So if you've detected that, immediate echocardiogram and send to this thing. Then there could be arrhythmias. Resting ECG may not show. You may have to have a Holter. So such patients with unconscious collapse, you must try to identify and send them off for other tests. Otherwise, conscious collapse, we have to look for postural hypotension. That is one very important thing, because they may not they may also come like a syncope. So every person who's fallen, sometimes what happens is, I had a person recently, one of my friends, who injured his shoulder when he fell, normal walk. And he went to the orthopedics, and everybody got caught up with the fact that they wanted to immediately operate and stitch up his rotator cuff and all those kind of things. I wasn't interested in that. I was more interested in, Murli, how did you fall? He said, he's a hatta-katta cardiothoracic surgeon, how did you fall? He said, I was getting woozy. I knew I have to go and sit down. There was a bench there. I charged for it too fast and toppled over on my shoulder. So I said, what's your standing blood pressure? I don't know. So I checked, he's 80 years old. His sitting blood pressure is 110. I said, what business you have to have a sitting blood pressure of 110? And he said, but my standing also is 100. It's above 90. I said, no, for a 90-year-old with sclerosed vessels, it's too low. So I had to fight with him. He thought, I'm only a geriatrician. My cardiologist told me to take these drugs. I had to ring up the cardiologist, plead with the cardiologist and say, can we take off this drug for him? Oh yes, doctor, please do. So what I'm saying is, and he's never fallen after that. He's had full assessment by a physiotherapist. He has no muscle problem. He has some peripheral neuropathy, and things are fine with him. Now he's battling this. So you see, Postural hypertension, again, is a very common thing in the elderly. One, aging itself causes postural hypertension. Then some of the drugs will cause postural hypertension. So, especially combination of drugs. Your patient is having, we try not to give alpha blockers. We give it only as a last resort. But the alpha blocker creeps in when he goes to the urologist, okay, for nocturia or for prostatic outflow. So he gets a tamsulosin or he gets a silodosin or something. And then people forget that now the urologists are very clever. Since many of the urologists, they also are on these alpha blockers and they say, oh my God, I didn't know it feels so woozy and all that. Now they're very careful with their patients and they also ask for dose reduction of the antihypertensive medication. But it's such a common thing that it should be at your fingertips to check postural hypertension, at least the first time that you see the patient. Then anytime he's feeling dizzy, giddy, going to fall, postural hypertension has to be checked. So these are some of the common causes, but try to identify. The majority of the falls actually are the conscious falls, slip. So it's the house, no wires like this, no mats unless they are, what do you call them? Skid resistant, and handrails everywhere. No wet feet. I tell all my patients, please have a bath sitting down, or soap your feet, wash them, then have the rest of your bath, because some people insist on having oil bath, in the south. Oil and soap is a horrible combination for falls.
About postural hypertension, just a second, I'll just finish this and then we'll take this. About postural hypertension, let me digress a bit. Hypertension in the elderly is often treated with medications, and we do advise that we should check standing blood pressure every hypertensive on antihypertensives. What is your view on a person who has 170 by 80 supine and 130 by 80, 70 standing? Do you increase the dose because the systolic is 170 in the supine? This query comes because it is a common thing, and I don't know whether I should treat the BP in standing or should I treat the supine BP to adjust my dose?
Always the standing BP, always the lower BP, because most of the time you're standing. Number two, if you try to bring the standing down, you're going to get a fall. So you have to play between the two, and it's a lesser evil. Standing blood pressure should not go definitely below 110. The other thing is to get the diastolic down. So somebody's got usually the elderly have isolated systolic hypertension. And so while we're trying to bring the systole down, diastole also will go down. So you cannot afford to let the diastolic go below 60. My diastolic blood pressure is 55, okay? But I worry about that. Yeah, I worry about that. My systolic needs a little reduction. Let it be, because it's been proved. You bring the diastolic down, it does not harm you immediately. You don't know the difference. But your tissue perfusion is suffering. So if the tissue perfusion suffers, you're going to deteriorate in your general health without your knowledge. And they've shown higher mortality with a low diastolic. I'm not talking about patients with aortic incompetence. That is different. It is people who don't have aortic incompetence.
So for us, diastolic blood pressure should be not below 60, and digital BP instruments will often give a low diastolic, lower than the mercury instruments. So rely on...
I didn't know that. Is that so? Okay.
So we should rely on mercury or even aneroid BP instruments, and not on digital in the elderly especially. Yeah, we can take a couple of questions. Yeah, so she's asking if home equipment to prevent falls.
No. The tests.
So she's asking about geriatric comprehensive assessment.
Yes. So it's all available, and the thing is, it's all there. Now there's one thing known as Edmonton Frail Scale, which I've got it on the thing. I can give it to you. It's like compressed, so like a screening test, which tests all the domains that go wrong. It tests cognition. It's just a screening test. Huh? It tests cognition, it tests functional capacity, you know, can you go to the market, can you get onto this thing, can you remember your drugs? And so this thing has been found as a very good scale, and it gives you a numerical figure which says frail, non-frail, vulnerable, not vulnerable, things like that. Yes, yes. So this is a very short scale, which even you might find it difficult to do in a consultation. You will have to get an assistant to do it because it will take up all your time. It takes at least 10 minutes to administer. So train somebody to do it for every patient before they come into you, if possible, or not that visit, another visit. The detailed geriatric comprehensive test actually does much more detailed. I think I can send it to you. So they are checking vision, hearing, just by questions and by doing simple tests. Like hearing is tested by going behind the patient and whispering something to him and asking him to repeat it. You stand in front, they will read your lips. So like that. Then get up and go test is just one of them. So comprehensive geriatric assessment can be done in full if you've got the time and you have somebody to do it for you. This Edmonton Frail scale kind of makes it a little bit more compact. The other thing nowadays, is this the time to talk about it? Yeah. ICOPE, integrated care of the older people. ICOPE. As I told you, WHO has identified this as the decade of healthy aging. So what they have proposed is for community. Now these are, we talked about when they come into your clinic. In the community, they propose that health workers who are not even doctors, nurses, anybody, even a social worker, can be trained to go out into the community and check 6 domains which are very important for something they call the IC, intrinsic capacity of the person. 6 domains, of which vision, hearing, cognition, psychology, nutrition, they call it vitality, and there has to be one more. These things are tested by screening tests, and the screening tests are like extremely mobility. So these are very, very simple tests. And if they pass that test, for example, the chair rise is one. How many times can you get up in 1 minute with hands like this? All these. If you pass the test, you're passed. If you don't pass, there are steps in that. If you don't pass the test, what happens? Then a few only get referred to the hospital. So these are being referred to the hospital even before they know there's anything wrong with them. So nutrition, very important for a concept of frailty, as we now think very big. Everybody's talking about frailty in the elderly. Nutrition, you may be well nourished, you answer these tests, you go. You don't answer these tests, your BMI is like this, you are at risk, like that. So for everything, for eye, for hearing, everything, mental, cognition, these are all the important things which make a person's ability to live independently in the community. That's what we call intrinsic capacity. So some things have been excluded, you know. So for example, heart, nobody's checking the heart, nobody's checking the BP in this ICOPE. Why? Because if you have decompensated cardiovascular status, you won't be able to do that exercise test. It may not be only a muscular thing. It may be something else preventing you from doing it. So everything can be picked up by these. This is all well validated, lot of studies and all that.
So what we will do is get the assessment, comprehensive geriatric assessment tests or scales from her, and we will pass on them on the group that we have created. Some of them may be not very difficult to implement, but can be time consuming. Since we were talking about falls, tell us something about the importance of recognizing and measuring sarcopenia. Can sarcopenia be measured?
Okay. So sarcopenia is wasting of muscle, literally. And it's part of another whole disease which I just mentioned as frailty. So frailty is something where a person, literally I think of it as a person who shrinks. So we come across some elderly people who are just like this, you know, bent slow, cognition may or may not be poor. So 5 things are there. Anorexia, which may be due to other things also, but what we're saying is excluding everything. They're anorexic. They have unintentional weight loss. Maybe due to the anorexia, maybe without. They have slow walking speed, okay? And they have low energy. And if you check their grip strength, there's a particular gadget which we all don't have, grip strength, that's also low. So out of the 5, if they have 3 things, we can say them as frail. Or the Edmonton frail scale that I talked about can also give you a number which says frailty. So sarcopenia is the most important part of that, all those symptoms, the grip strength, the slow walking speed and everything, sarcopenia in frailty in the adult. And we are not talking about muscle atrophy in a person who's had a stroke and all those things. Those are well defined. So why does this happen? What is the biological basis of sarcopenia, and I extend it to frailty, is a subject of intense research. And they've coined a word called inflammaging. Inflammation, low-grade inflammation in old age. So some people would like to believe that we age because of a kind of molecular disharmony that is taking place, which is causing inflammation by, what means not by bacteria per se, but by reactive oxygen species, you know, these ROS and some low-grade viral infection, some toxins, some radiation, toxins in the air which we don't know exist. So all these things together act on the mitochondria. There are certain types of molecular things like epigenes and all that, and they cause inflammation. And this inflammation kind of eats up your muscle mass, eats up your vitality. It's like having a slow tumor inside you, low grade. And they say that inflammation is the cause of frailty. So people are trying to see now how can we tweak that? But that's quite elusive at the moment. So if you identify a frail person, what you have to do is things which are partly successful, because we don't know how to retard the process. There is no magic pill. Ashwagandha and ginseng and all those things just don't work. But so at the moment, no answer from allopathy, but they do say exercise and, you know, resistive exercises as far as possible to improve that muscle hypertrophy. So in the West, the old people, the 75-year-olds, are all going to gyms and doing all kinds of things. So I don't know. So you have to be very careful about this, because if he's got hypertension, please don't make him do resistive exercise. He's going to get a stroke. So at least physical fitness with the help of with a physiotherapist or whatever. Then nutrition. Lots is going into nutrition. And here we come across this thing about what is nutrition. Nutrition is protein. It is antioxidants. It is micronutrients. Less carbohydrates, less fats, protein. In a vegetarian country, in a vegetarian state, how do you give protein? To the extent, now the whole world is going through vegetarianism, which is, I think, a good thing. But actually, there's nothing like meat, as far as I'm concerned. But in the vegetarian domain, there is a whole lot of things one can do to give all the amino acids that are required. And so protein content has to be increased. And I am a strong proponent of soya, though I hate it. And I think that if there are people here who know how to make soya palatable, tasty, please tie up with industry and bring us something, because whatever soya is there now is just horrible. But soya has got such a high protein content, but of course there's a little bit of fat, not that much as. And then again our peanuts, you know, we are a country where peanuts are growing all over the place. Peanuts, though the fat content is high, it's a good source of protein, you know. So as a snack we all eat, but the snacks are full of salt and what all. So what you do is you take raw peanuts and nicely get somebody else to roast it for you. And keep popping it in your mouth and feel no guilt at all. Because you've got your protein, you don't have the salt, and your craving for food is satisfied. So I think we as Indians are well placed to show the world how to increase the protein content of diet, especially for the elderly, and make them strong. And then, I don't know how many people are here for whey protein. How many people like whey protein? Only 2. You like whey protein? Do you give people whey protein? Please tell us your experience with whey protein.
I don't know what are pure, ISO.
So whey protein is actually leucine, which is an amino acid. I mean, it's got the it's got protein in the whey, the water that comes out when you take off the rest of the protein. And it helps to incorporate amino acids. I think it's leucine which is there. Is that what you're saying? Incorporate amino acids into the muscle much faster than anything else. So whey protein is what is taken by, it's a huge business. It's taken by all these athletes, and because it's not a drug, so it's allowed by the anti-doping test. They put on muscle and it's very effective. But there's a slight caution. There's few small studies in the elderly, and it's not bad. But they warn that the time is not yet ripe to give a prescription for whey protein for the elderly because it is not a pharmaceutical agent, it's a nutraceutical agent, which means that it is not as rigorously regulated and purified. It may contain some toxins. And so the road is not clear. But just keep this at the back of your mind.
No, not
nephrotoxin. Maybe, but it's not directly that. It's got some kind of toxins, like even things, rare elements like titanium and all that.
Lead, any contaminant.
Yeah, which may not be. Whereas for drugs, we are very, meticulous about it.
What is your recommendation on gram per kg body weight of protein?
Well, they say 1 gram per kilogram, but I doubt that anybody here takes 70 grams protein. Because I don't think I take 70 grams protein. I'm more than 70 kgs. So what happens is we forget to count that 7% of our cereals actually also have protein. We only look at the actual meat. Any one portion of meat is 20 grams flat protein, one serving. If you take a serving of a vegetarian protein like dal, it's 14 only. It's 10. It's almost half the quantity of a meat. But if you can take, and remember, vegetable protein doesn't contain all the amino acids in that dish. So that's why we don't call it second class protein, but we call the other one as a first class protein. But the point is you easily overcome that by taking different forms of vegetable protein. So what amino acids are lacking in one will be made up by another. So vegetarian diet is absolutely perfect for the human body, doesn't have to consume meat. However, one drawback, anyone knows? B12. B12. There's no B12 and there's no cholesterol in the plant kingdom. Sad. No B12 and no cholesterol. They don't have B12. Milk has got B12.
Slight.
It's an animal product, slight. But for vegans, fortunately in India we don't have this vegan class. Okay?
We have.
Those who are lactose intolerant Indians. I think Indians, we love our milk. We love our ghee and all those things. The ghee, all that. So there is some B12 in that. And that's usually sufficient. But elderly vegetarians are at great risk of B12 deficiency. All elderly are at great risk. Fermented yeast, that will have. Yeast will have. B vitamins a lot, but B12, I think, maybe you're right. But no. It's negligible. Oh, curd, because it's milk. Yes. But it's very small. And then as you age, the stomach lining becomes thin. The hydrochloric acid comes low. So it's unable to extract B12 in the food. But if you take a B12 supplement, there's no doubt. There's no problem. But you need acid to cut out separate that B12 from your food. So B12 supplementation I freely give to all my patients, but not what comes in a multivitamin. I don't give multivitamin to a person who's got good teeth and has got a good appetite. I say you must get your multivitamins from your diet, because in addition to vitamins, you've got many other micronutrients which you don't get in a pill. Fruits is something which my patients hate. I do not know why. So I don't know about, yes. No, I don't think so.
He asked if B12 gets destroyed by boiling of milk. Probably.
I don't know about that. I haven't heard of that.
No. Do sprouts contain B12?
It's
No.
not B12, but it's many other good things.
Protein
Many other
especially.
good things, proteins and many other antioxidants. And
We'll not detail nutrition for the moment. But we'll... what is the relationship of the gut microbiota to inflammatory processes of aging?
I don't know the answer.
Nobody probably knows the answer. Yeah.
But it's very important in disease. Yeah, gut microbiome is now a big thing. It's very important in so many different aspects. I don't know about aging as such, but certainly in GI disturbances and in general immunology, it's very important.
We discussed instability, we discussed falls, we discussed sarcopenia.
Falls and drugs.
Falls and drugs.
Okay. Now this diuretics which I was expounding is one thing which can give rise to falls. And then we come across this huge thing called benzodiazepines. Can I ask? Of course, neurodegenerative, we are talking now of just drugs. Any peripheral neuropathy,
Parkinson's,
all of them will give rise to falls. But in terms of drugs, I just want to know, how many people there are who do not prescribe benzodiazepines?
Consciously do not prescribe sleep ke liye benzodiazepines. Okay.
That's very good to know.
Then you may ask them this follow-up question. What do you prescribe for sleep?
Yes, what do you do for sleep then?
Dr. Kumuda, what do you prescribe for sleep? Nothing, you let them be insomnic.
Somebody is saying something. Sleep hygiene.
Melatonin.
Melatonin. Okay, is it useful? Melatonin? Melatonin is not useful in everybody. It's only useful in those who have sleep onset insomnia. And also, they're supposed to take it 1 hour before bedtime. It doesn't help many people. I also do prescribe. Do you get it freely?
Yes.
Yes? Okay. It's not so freely available. We, of course, think of it as jet lag medicine. It's not 100%. So sleep hygiene. Can we allow her to tell us about sleep hygiene? Would you tell us?
Dr. Adwari,
Regular waking hours, she says. Always get up at 6 or 5, whatever.
you'll have to repeat what they say because they...
Sorry, no? No stimulating activities,
like
no
telephones,
caffeine,
television.
no mobile phone. Tea, coffee, they all contain caffeine, stimulants. No alcohol. Hot shower before bath. As Indians, we don't take bath in the evening, frankly. We like to take our bath in the morning, okay? So nobody so far has said exercise.
Okay.
Physical exercise and tire yourself out, but not late in the evening. It should be early on in the evening or morning. That exercise has to be there. No afternoon naps. That takes away. And then they say if you're lying in bed and you can't sleep, you've counted 2 crore sheep already. Get out of the bed. They say 30 minutes, get out of the bed and do some pleasurable activity, not Sudoku, not phone, not WhatsApp, music, something which. Has anyone tried that? I've tried it. Nothing works. For 2 years, I did a 5,000 jigsaw puzzle. I just got up and I put on all the lights and I put the pieces in. When I was exhausted, when my mind was exhausted, then I could sleep. That's not
The solution.
so, yes.
What
Yes,
is your...
you're absolutely right. But the thing that but what happens to people like me who don't want to read the Mahabharata, you know? Very good. Tryptophan, threonine containing things, or serotonin enhancing things like banana and green tea and all that. I tell you, somebody in their wrong mind came up with these things. You try doing it. But all I'm trying to say is the time is ripe for you guys to come up with some things and don't just say it. Do some research. You know, I'm not a researcher, but I have great respect for researchers. And I feel the time is ripe when now every doctor must get together in groups and do little studies. And none other than
Insomnia.
of something, everything. Decide on a research product. Yes, somebody.
He says one prayer to the Lord. Yeah. He takes 2 minutes to sleep, go to sleep.
Sir, excuse me. Are we allowed to ask you your age?
What's your age? He's
No.
63.
Okay. So you are young old. Okay. Please, I challenge you when you're old, then you see what.
Okay, so before we cut this short by asking you, how much pharmacotherapy should we give, if at all we give pharmacotherapy for sleep? What pharmacotherapy?
Zero.
Zero.
Zero. I have never given. I can put my hand on my heart and somebody pleads with me and said, please give. I have taken, maybe we can ask, how many people have never taken? I have taken Valium those days once in my life. And it is fantastic. It's like you put off the light, you're out, and you get up next morning, there's no hangover. It is fantastic.
Okay, I'm going to have a debate with her. Okay, I prescribe sleeping medicines, sleep aids, including benzodiazepines. In fact, lorazepam is my go-to drug. In chronic insomnia, where CBT, cognitive behavioral therapy, is the approved form of therapy for chronic insomnia, we do know that CBT is not easily available, and it is a tedious process. I have had relatives go through CBT. And it is as useless as melatonin, let me tell you that. But the point is not that. The point is it's not available, CBT. And is insomnia a risk factor for anything? Like people say sleeping less than 5 hours is a risk factor. Do you think it's a risk factor?
Definitely.
Of what?
Mortality.
Increased mortality. And is benzodiazepines a risk factor for increased mortality?
Yes.
It is. So now
It causes not only dementia, it causes falls, it causes delirium, it does everything. So both ways you're stuck. So better to have normal mortality with low sleep rather than enhanced mortality.
Natural mortality instead of iatrogenic mortality. So that let the patient be miserable, But let them
Miserable,
die.
craggy in the morning, throwing tantrums because he didn't sleep. That's better
Yeah.
than have a zombie in the morning. But one thing about, I mean, I'm very surprised that Dr. Shah, whose knowledge of pharmacology is better than most pharmacologists, has the audacity to say that he gives benzodiazepines. Do you know the pharmacokinetics of benzodiazepines?
I would not give it in a 75, 85-year-old, but for a 50-year-old who has chronic insomnia, I would gladly prescribe it.
For how long?
It is a lifelong medication.
You can prescribe benzodiazepines.
For not
Even
more
I
than
will give
30 days.
benzodiazepines for 7 days. For a person who has had such a severe anxiety,
Yeah.
daughter failed in the exam, somebody died, somebody had a divorce, certainly you have to. As an anti-anxiety, there are other medications, but that's the best. But beyond 7 days, in my department in medicine, nobody could prescribe a benzodiazepine for more than 7 days. That prescription would come to me, but it never came to me. Either they didn't give it to me or nobody actually prescribed it. Because the body fat increases in the elderly as compared to the body water. If you think of a two-compartment model, benzodiazepines are highly soluble in fat. So they get deposited, the volume of distribution, it's all distributed in the fat compartment of your body and slowly released over the day. So you're drowsy in the day. Even if you're not drowsy, your reflexes are a little wonky. If you're driving a car, you'll have an accident. If you're just walking on the road, you'll have a fall. And then your mental processes, you'll get dementia. And nobody will know it till you get admitted in a hospital for a hernia operation or something, and they forget to give you your Ativan. You'll go into delirium next morning because of withdrawal. So, you know, benzodiazepine. And then Z drugs, the zolpidem and all those drugs, they say they're less addictive, but not maybe at lower doses demand, but I have never been impressed by them.
Magnesium as a sleeping aid.
I think you. So it's your, if I may be so rude as to ask you, on what numbers do you base this? How many people you have given? And was it a randomized controlled trial? Sorry, we don't accept, unless you do an RCT, we don't accept. So please do the study, community-based study. You know what you need to do? If you're a researcher yourself, you know research methodology, you can do it, but why don't you invite a researcher? Talk about simple research method, research in a community setting. Very few people in the world are doing it, but it has to happen. It has to happen outside teaching hospitals. Research has to happen on the ground. So get hooked on to this, because it has to be high quality research. In the beginning, let it just be an observational study. Then you can give magnesium to one lot, no magnesium to another, match your groups, and you come out with this thing. No, you have a tool to test sleep, whatever. I think it can be easily done.
Yeah. We will. So what she's asking is, if a person is prone to anxiety and has to go into that MRI machine, would you give anything?
If it's very severe, that is just a one-off.
One dose, yeah.
And for outpatient procedure nowadays, they give midazolam, which is a benzodiazepine, very short acting. Cannot give, but we wouldn't give it for an MRI. I've never heard of somebody getting so much, but odd patient. Yeah. Oh, you.
Okay, we'll go. Yeah, last question here. He's asking daytime excessive sleepiness in old age. How do you kind of investigate? What do you look for?
First thing is obstructive sleep apnea. So it is more common than we think. It has very bizarre manifestations, but the most important one is daytime drowsiness. And if you have somebody who's constantly bashing up his car, please think of daytime drowsiness. They will deny that they slept, but they sleep off at the wheel. How many people at the age of 80 here are driving? I don't know, but it's only going to increase because now we are a driving population. I would refuse to give up my car in the next 5 years. Never. So, so if I have sleep apnea, which I have, I've got to make sure that I'm correcting my sleep apnea because that's how I detected I had sleep apnea.
Wow.
I
Bang.
dashed into the median at 3 in the afternoon, and my only fear was, did anybody see me? How can the shame of having dashed into the median when nobody was pushing me or doing anything. So I immediately got my test done. I knew before that I'm having it. And they rang me up. I had just had a home screening test, not the full blown. They rang me up and they've got you with severe sleep apnea. I said, how dare you say that? I'm not so obese. So now I read up and found postmenopausal women, 20% have sleep apnea because this part becomes so loose, it just obstructs. And daytime drowsiness. So I was wondering why my PG students, when they're giving this seminars anyway, PG seminars are boring. But even the exciting seminars, I was falling off the chair. It was very embarrassing. When I started my CPAP, I'm fine. So, daytime drowsiness, please look at that. Also look at poor sleep at night, insomnia per se. And then, of course, the use of benzodiazepines. Somewhere he's taking a benzodiazepine unknown to himself or to you. These are some of the things. And of course, heart failure, hypothyroidism, all these things are, heart failure can give rise to severe fatigue. And they don't have breathlessness. That's the part of the old age bizarre symptoms. There'll be no breathlessness. But they'll have insomnia because they can't lie flat. They don't know why they can't lie flat. And then such severe fatigue that they just... One good thing you were talking about insomnia is, I think we should look at yoga. Yoga, that lady has gone. So I find myself and with others, I don't want to just promote I'm talking too much about myself. If you relax physically every muscle in your body, it's much easier. Yes, madam.
She would suggest Vipassana meditation
I
for
think
sleep.
these are fantastic, unexplored things. We know about it, but we don't know its relationship to sleep.
Again, something in both yoga and Vipassana, we would need RCTs to convince ourselves also. That feedback is, what she's saying is that the breath, if she concentrates on her breath at the time of sleeping, that promotes sleep. Yeah.
I fully agree with that. But to prove to the world, see, you, by telling me, I believe it.
Anecdotal for
It's anecdotal. We must do the research. There's so much that we know as knowledge, but we can't prove it. But it's not enough to say I've done it. It's not, no, you have to prove it. So prove it.
Yeah, we'll go ahead. Yeah, yeah.
Yes. Good. So we'll await the research.
She spoke about a very interesting thing. Snehal, you want to say something? What she's saying is maintaining sleep hygiene, of course, and sleep diary with cognitive behavioral therapy probably. So yeah, this is an area where we probably have a lot to do.
But one more thing, since sleep is so central to much of our practice, we fail to realize there are certain drugs and certain comorbidities.
Which cause insomnia.
Yeah. So anybody with COPD, GERD actually, because some people don't have the pain, they just cough, and heart failure, and menopause by itself per se. Drugs such as beta blockers will deny you sleep, and steroids, and what else? Pain. So, before you label as a person as pure primary insomnia, I don't think that's a word, primary insomnia, please ask all these questions. And you may not be able to take off the drug, but if it's a beta blocker, some of the newer ones, like nebivolol and all are much better in this, you can try.
She spoke about equivalent, wait a minute. She spoke about equivalent symptoms, sometimes that insomnia can represent something else, for example. So tell us about some geriatric symptoms which may be actually due to causes which we don't suspect. For example, you said cough may be heart failure related when patient does not have dyspnea, because the patient does not walk, so dyspnea and exertion is not noticed and only cough comes up. Any other symptoms that you can think of?
Which actually is the big elephant in the room we didn't talk about, insomnia. Think of depression.
Insomnia as a symptom of depression.
But having said that, most elderly insomniacs are not depressed. Your common garden guy he's not depressed, okay? I'm just saying. But in that group, there'll be a few who are depressed. Just like there are few who've got unidentified heart failure. There are few who actually got asthma or COPD. So if somebody comes with insomnia, which you have tried all the sleep hygiene or anything, try to get that constellation of symptoms which might suggest that he's depressed. And as we were talking, depression is something which is poorly recognized by general practitioners and all non-psychiatrists all over the world. In the West, in America, they overdiagnose. Everybody's depressed. They themselves will go and tell, I'm depressed. They go straight to a therapist. In fact, at one time they said, can we put Prozac in the tap water? Then all of us will be bouncing away. So from that extreme, we come to India. In my practice in CMC, I found the psychiatrists always told us, you guys just don't diagnose depression. And when you send us depression, they are suicidal. So you aren't doing anything. So we had many courses, so we were a little bit better in diagnosing depression. So insomnia. There are many other cues, but insomniac patient, you can ask them a few questions. Are you feeling tired? Yes, everybody's tired. But is it excessive tiredness without a cause? If they've got heart failure, yes, tired. If they've got something else, but unexplained tiredness. Unexplained is the person says, I'm so tired, I can't even go and cook. I can't do cook. Okay, do you want to cook? Or you just don't want to? No, I don't want to cook. But somebody says, I love to make the biryani, I just don't have the energy. That's also a plus point. But if don't like to do it, and I don't have the energy to do it, that's a stronger thing. Oh, my bahu bhi kabhi saas thi, or saas bhi kabhi bahu thi. I don't like to see it anymore. Pleasurable activities are less pleasurable now. So then everything, my family is falling apart and it's all my fault. Guilt. A feeling of worthless. What did I do my whole life? I just stayed at home. Finished my job. There's a feeling of worthlessness. Okay. So then lack of appetite, which is not due to any other cause. Maybe constipation. These are all the vegetative symptoms of depression. So constipation, which is not due to anything else. So you come across a mixture of 8 to 9 things. And then you have to ask that one question, which I hate to ask. Do you want to? Suicidal intent. Do you want to kill yourself? All of us feel that if we ask somebody that, they'll go and kill themselves the next day. But I'm assured by all my psychiatry friends that every one of us has entertained the thought of killing ourselves? And by asking that question, you will not push anybody, but it feels a bit crude to ask that. So you ask in a nice way, do you sometimes feel as though, why am I living, you know? And they'll, as I was telling Tushar the other day, one of my patients had so many problems, I don't know what was wrong with him, and so I did the easy way out, was to do a whole lot of tests, you know. When you don't know what to do, you do a whole lot of tests. As this person was going out of the gate, I said, something is wrong. I said, come back, come back, come back. Oh, do you ever feel that life is not worth living? How did you know, doctor? Every time I go in my house, I want to climb this top and jump from there. But I'm a true Christian. I think it's a very bad thing. I sit down and pray every day. God, don't let me jump off. So you see, that never came out in the consultation because I didn't give the space to the person. I was giving only tests to do. So you have to have that in your mind, that the highest suicidal person is adolescent and old age. Because when you're a young adult, you've got family, you've got to do this, you've got goals, you've got this thing. And if you're performing reasonably well, you've got a good sense of self-esteem, this, that, and that. But, you know, and it's not feeling sad. All of us sometimes think that feeling sad is equal to depression. Sadness is only one tiny bit of depression. So all these things, if you have it, diagnose depression early, if treat it, but if it's major in the sense that a person has got suicidal intent, has planned it, has attempted it, don't try to treat that person. Please send them straight to a psychiatrist. So in insomnia, one of the things is that.
I think we'll break for tea.
And this early morning waking, 2 o'clock, that's more.
Is a symptom of depression.
Rather than sleep onset.
Sleep maintenance problem may be a symptom of depression. Easy crying as a symptom of depression. Would you say that? Easy crying? I cry while watching movies. Makes me suicidal. Yeah,
Yes, it could
can be of course a symptom of
anxiety and depression. But then you must have other things. You must have at least 4 symptoms.
Okay, we are a large crowd, so please bear with the services, but tea is ready, and yeah, and we have 2 more topics to cover, which is immobility, impaired cognition, and a few diseases to cover. So please be back in 10 minutes. we'll take the rest of the topics. Before I go to the other giants, amongst the geriatric giants, there are a few diseases that I want to ask her about and how they should be differently managed in the elderly than in the younger population. So, how is it different to target TSH in hypothyroid patients in the elderly? What makes the elderly different?
Hypothyroidism, especially the subclinical variety, is a disease which has been made into a worse disease by doctors. When I say that, somebody has, if the lab value is 4.5, no, I have seen, not talking about the elderly here, if it's 5, the cardiothoracic registrar has already started the 80-year-old on Altroxin. So I told him, what are you doing? Hey, it's above the lab value. I said 0.05 higher, and I use the analogy of a bullock cart, that is my 80-year-old, being attached to a high-octane jet fuel and dragged along, the bones will break. Okay, we don't want the metabolic rate to be so high. Please stop it. So I think, on the other hand, if you, even subclinical hypothyroidism untreated can give rise to cardiovascular disease and atherosclerosis. So we have to play between these 2 points. If you give too much of thyroxine, not the extreme of what I said, bullock cart, but you will promote atrial fibrillation. You will promote osteoporosis. And they will happen so subtly, nobody knows at the end of it. In fact, some people in America are thinking whether the high level of atrial fibrillation, which anyway the aging atria will do, and we are promoting it by perhaps giving this. And I have seen patients who are in this dilemma, and so I'm very cautious about starting. So subclinical hypothyroidism, where your T4 levels, free T4, total T4 are normal, and your TSH is somewhere below 10. The standard teaching is, do not do anything, because if you want to do another lab test, you're very, this thing, it's a young female and all that, you can do the antibodies, okay? Do the TPO, because if the antibody is elevated, then they've got Hashimoto's, and they will progress, don't have to wait. If they are antibody negative, please wait for 6 months, unless it's, they've got a lot of symptoms also. If people have symptoms, because our lab tests are not that accurate, so they've got this weight gain, they've got everything else, and especially if they've got dementia, in the elderly, hypothyroidism and dementia, then go ahead and treat, but not everybody. So I don't know whether I have a particular value, but after 6 months, if the hypothyroidism, even if the thyroid level is normal, you can treat, because it will progress. So that's all that I have to say. In pregnancy, and of course, who all are treating children, I don't know. Hypothyroidism in children must be treated by an endocrinologist, because all to do with bones, growth, it's too complex. Hypothyroidism in pregnancy, please don't bother. Give it off to somebody, because, if you give too much, and the reverse also true for thyrotoxic. Any thyroid disease in pregnancy, very close monitoring, because its effect on the fetus is there. So that is all I can say. Do you have anything else to say?
I think that what you said is just perfect. What is the difference in diabetic drugs in the elderly, in the very old especially? What diabetic drugs should we avoid? What should we give?
So nowadays, the sulfonylureas, which is what we grew up with, they came like a flash out of the other drugs, what were they? First generation?
No. Tolbutamide.
Tolbutamide, chlorpropamide and all that. Then the glibenclamide came. In 5 milligram doses, they just made sure everybody became all right. Now they have come into disrepute because of their metabolic problems. Not not these don't give metabolic problems, sorry, the diuretics.
Hypoglycemia.
But they give rise, they're very long, the glibenclamide is very, very long life, long half-life. So that 100% must be not given to an elderly person, but having said that, it's the cheapest drug. I don't know what the cost is, but it's the cheapest drug. So if you've got a down and out person who's diabetic, please give him a lower dose because it's like water. You can't give him gliclazide, which is hellishly expensive, but is the best sulfonylurea apart from glimepiride. Glimepiride, again expensive, but it has, it's good because it has got extra pancreatic effects on the muscle. It promotes what they say, I don't know whether it's the glucose 4 transporters, GLUT4 so it allows intake of glucose. Do you agree with all that?
I don't know this.
You don't know?
I don't know
Okay.
this.
So it has an extra pancreatic effect. So glimepiride is the thing. When it first came, I didn't like it. You know, there's a thing about liking medicines being biased against some medicines and being, you know, like sambar. One of my teachers told me, if you're making sambar one way and it turns out good, why do you need another way to do it? So that's not a good idea. We should embrace new things, but we shouldn't go with the latest drug, the new fad. Why? Because it may have some side effect which we don't know. In phase 4 surveillance, it may come out. And don't be the first one to start a very new drug unless it's something great. Let other patients get the complications and then you give it. So
I think that is a very good instruction for us. A new drug comes, say semaglutide, for example. It came, semaglutide is
Yeah.
GLP, 1RA. Say semaglutide has come, it is in the news, etc., and you are tempted to give it. Wait for 6 months, 1 year, 2 years. Let others give it. You see what happens now. Semaglutide we know can cause intestinal obstruction. We know it can cause pancreatitis. We know it can cause worsening of retinopathy, proliferative retinopathy. These things will gradually come up. These are rare side effects, and still semaglutide is a bestseller all across the Western. But we should, as she said, let others get the side effects and our patients be safe for some time.
But coming back to the drugs, so long-acting sulfonylurea is out. In general, the present recommendations are to use sulfonylureas as the last resort before giving insulin. But having said that, I'm used to metformin first, then sulfonylureas, then DPP-4 inhibitors.
How's your insulin use in the elderly?
Yes. So, and then insulin, we used to say, oh, this insulin. But with the newer insulin, especially the long-acting glargine, see, all of these has come after I have become a geriatric physician, okay? But still one has to learn on this thing. And I was very reluctant on this nocturnal insulin. How to give insulin at night when he's not eating, will have hypoglycemia. That's all rubbish, okay? So this, all of you know this already, but I had to, one thing about medications, you have to get it into your DNA. You have to be confident that no matter what they write, you are comfortable because you've been making sambar in one way. Suddenly they say Lantus. So it took me a while, but now I will say Lantus is wonderful in an older person, slow acting, and by the time this diabetic has had so many years of diabetes, he's come old age, his pancreatic beta cells have fallen out completely. So he needs insulin. You can't flog the beta cell anymore with your oral drugs. So I'm very happy with Lantus. I'm a very wary of supplemental short-acting drugs. What do you call them?
Rapid-acting insulin?
Analogs, insulin analogs. Yeah, rapid-acting. I'm very wary of them because hypoglycemia in the elderly is a more severe danger than complications of hyperglycemia because they're not going to live very long. Do they have long time to develop complications because of this thing? So the targets have been revised. Now remember, that's why you have to have a healthy for the research that comes out. So they said 6.5. You cannot, hemoglobin A1C. You cannot make an 80-year-old 6.5. He'll die of hypoglycemia. So it has been revised now. 8%
In the
is
very old.
very old. 7.5 to 7 in our age group, 60, 70. And for the younger person, strict 6.5. There's no doubt about it, because you've got so many more years to live, so many more chance to develop microvascular complications. Now I believe even macrovascular complication due to sugars alone, because we used to say macrovascular is not due to sugars alone, because there are so many others, hypertension, cholesterol, etc. But the microvascular is definitely dependent on your ambient glucose level over a long time. So I think as a healthy rule, a common rule is look after the person's diabetes, but not as vigorously as you would for a younger person.
What is your comment on statin use in the old or the very old?
Yeah, we
What
did
is
that
your-
in this thing. So don't start a statin as a primary prophylaxis in somebody above the age of 75. So the first time he may look healthy and fit, and whatever he had came for his regular master health checkup, and the cholesterol was 250 or 300 or something. So after 75, why do we say this? Because it's a prophylactic. He's going to get a heart attack, but what's his longevity? At 75, in our Indian standards, he's not going to live more than 5 years. Average person. So you don't want to give a drug which is going to cause side effects. Supposing he's not diabetic, he may be pushed into diabetes by your use of statins. And then he may be the unfortunate one who gets the myopathy and all that. So universally now accepted unless there is some other overriding factor. That is, he's already got peripheral vascular disease in his legs or something, you see. And he's got this, that and the other. And he has a cholesterol of 300. Then of course, yes. In general, I also find that people just look at the cholesterol level, even in younger people, and start the statin. If it's anywhere 201 also, they will start. No, you have to look at what is the cardiovascular risk in 5 years, 10 years if he's never had it. If he's got the you've got the 5 important risk factors of family history, obesity, smoking and all those things, then at a lower level itself you can start. But if he has no risk factors, then cholesterol alone is not an indication for starting statins. You have to do non-pharmacological and then. So I think those are the general rules which you're all well aware of. I think statin is overused. On the other hand, I feel statins is a fantastic drug because it's really cut down cardiovascular atherosclerotic disease to a great extent. But we have gone, because my personal feeling, which I'm anti-pharma, is that we are pandering to the pharma industry, and when they raise the level of cholesterol over consensus, they fly people into some nice lovely island and come to a consensus meeting that from 200 we will raise to 200 and we will reduce to 190, finished. It translates into billions of dollars. So please we should be realistic.
One lesson that we can learn from this is in primary prophylaxis for dyslipidemia, if a patient comes to you with a health checkup, is 75 plus, there is no atherosclerotic cardiovascular disease so far. If this patient has an LDL cholesterol of 190, LDL of 190, which is a recommendation for a younger person to start a statin. At 190 in a 75-year-old, do not start a statin. Now, another debate will be if the patient is diabetic without any atherosclerotic cardiovascular disease and at 75 or plus, you find an LDL, should we start a statin for that patient? I don't think research gives an answer to that, but would you start in a diabetic who's 80 years old with an LDL of 140? I'm asking her because I think our answers might change.
At the moment, I don't think an 80-year-old, mainly because the effect of your cholesterol reduction is going to have the atherosclerosis not then, but later. He's a diabetic, I agreed. Remember there were days when the moment you were a diabetic, the moment you were a hypertensive, you were started on antiplatelet medication as primary prophylaxis.
Aspirin.
That's gone now, because aspirin caused more harm. Statins anyway have got so many things against them. Why do we want to give a drug to an old person and harm him? Remember, every drug can have the potential to harm. Why should we harm him when his lifespan is limited anyway? Why should
I think the argument should be that somebody above the age of 75, diabetic without any history of atherosclerotic disease, the argument might be this, that if you give a statin, then you're causing muscle problems, you're potentially causing worsening of diabetes, and your benefit will be seen over a 10-year period, and that itself might not be a great thing to do. So we might have to gradually become more conservative in our statin therapy than we are currently.
And as you have said in your little thing booklet, that rosuvastatin is much better than...
Yeah, that I think we know that atorvastatin drug interactions are significant. Yeah, ma'am, last. Yeah, we will come to that. We are just going to discuss that only. So, use of fibrates in high triglycerides as a general rule on in the elderly both. What is your?
As a general rule,
is it
yes.
overused?
If it's, I
Fibrates are
have not
overused.
seen it being over. In fact, I think it's underused.
Phenofibrate we are talking about.
Yeah. Most people just give cholesterol. And actually the triglycerides are definitely in a type 2 diabetes. The dyslipidemia is more in terms of the triglycerides, which have their own morbidity. So, yes, it makes sense. But the moment you combine phenofibrate with cholesterol, the myopathy, with statins, the myopathy is much more increased. So I would restrict phenofibrate to when you can't, even the statins alone will bring down your triglycerides a little bit. So unless it's 700 or something like that, I would first try with they'll always have some cholesterol elevation. I would start with the statins. If it doesn't come down, then I would add phenofibrate.
What is your take?
How about other things like ezetimibe B and now this new PCSD?
Yeah, so in the we have probably studied
You
that.
studied it, okay.
So bempedoic acid, ezetimibe, and I don't know how.
PCSK inhibitors.
PCSK9 we don't have experience with
That,
inhibitors.
Yeah, but
don't have. Okay, so that is about. Let's go then to treatment targets of a few things. Yeah, Yanni, we discussed that, HbA1c, etc. we did discuss. Okay, I think one area that I wanted to discuss is menopause, which is not in this list. What are the problems related to menopause and...
Menopause is, it's because it happens to women who are long suffering, used to disability. We haven't made much of a noise about it. But if this was happening to men, they would have changed the world. They would have all. But we women, we suffer from this. So menopause, there was a time you all remember when we were giving hormone replacement therapy to every woman who on the verge of menopause, and suddenly women were looking young forever. And I thought to myself, how dare we, I'm very conservative. How dare we play with nature? Nature says you must have menopause, and now you're reversing it. Just because you want to stop bone fractures. It was basically iron heart disease and all those things. But it's unphysiological. So I never gave my patients hormone replacement, but in front of me I saw menopause clinics, bi-weekly clinics, then daily clinics, and they were filled with people who were then put on to hormone replacement. And then, of course, that one study, the Women's Health Initiative study came, and overnight the menopause clinics stopped, okay? Because there was higher incidence of heart disease. There was higher incidence. I mean, there was no, even though breast cancer and DVT, we all knew was going to happen, but heart disease was there. So my take on menopause is that all your patients you must look at all the somatic symptoms and all the mental health symptoms. You must be aware of it. And when your patient comes, we have to handle them as far as possible with non-pharmacological approaches, but some of them will require hormones. And our gynecologist, when I want to give, if they don't have a uterus, you can safely give them estrogens, but if they have a uterus, then you have to give the progesterone and all those things. I would happily give to my patients and send them to the gynecologist to do a surveillance. The gynecologist would tell them, this doctor is giving you this precancerous medication and all that, and you please stop it. So there is that tussle between the gynecologist and us. And so if somebody is having unbearable hot flashes, they can't function. Some people have a little early menopause, you can give them. And certainly, if they've had a hysterectomy, they should have, if they're very young age, but the gynecologists never do it. So we should give hormone replacement, but proper surveillance. The other thing of, insomnia, depression, very common at the time of menopause. I'm not looking at the cosmetic things and all, but there are a whole host of issues for menopause that we should look into. And one of the things is the vaginal atrophy. The vaginal atrophy, of course, for the sexual thing, because the male libido would still be there, can create a lot of problems in a marriage. And the question of vaginal estrogen. So not only the sexual problem of dyspareunia, but also the urethra actually goes inside with the atrophy of the labia minora and all that. And that gives rise to a lot of colonization and frequent urinary tract infection in a menopausal person. Without infection, they have severe dysuria, vaginal spasm, and one thing which I found out was also gives rise to vaginal discharge. We usually think of vaginal discharge as being due to infection, either candida or trichomonas or your bacterial vaginosis or those kind of things. But pure vaginal atrophy also can give rise to a discharge. I mean, usually there's proliferation of thing, but you keep treating it with your pessaries and all that, it just keeps coming back. The discharge can be very annoying. So be very generous with the use of vaginal estrogen.
Vaginal estrogens.
Local estrogen is an answer, and I can tell you that the gynecologist, one gynecologist, when I said, how much do you use of this estriol and Premarin, she said, is it available? Which told me that she doesn't use it, because I use it freely and regularly for all my patients. My nurse knows to teach them how to give it. The only difficulty is, what is the cycle to give it? Everybody's got their own cycle, okay? So whatever you do, there's a cyclical one, that means you give for 2 weeks, then you stop for 2 weeks, and one is you give regularly for 2 weeks, then you give on fortnightly. There are many, many. So up to 1 year it takes in tapering doses to build up the vaginal epithelium. And the patient will slowly, all these symptoms will go. They'll go away to the extent that they say, so I said, all your urinary burning, everything gone. I never had. You see, they've forgotten completely. You see, don't let them forget it. Because after 1 year, what happens? So I've read up the literature on this, and it says there really may not be any harm, but there is no published work to say that there's an increased chance of vaginal malignancies. Of, not uterine so much as vulval and all that, or even maybe uterine. So there's no study. But if you look in blogs, they will say, how can you just give for 1 year? After some time, again, it'll atrophy, no? So you need to keep telling the patient, keep it with you, and the moment you start getting those symptoms, just take it. Even once in a month may be enough to maintain it, but there's no published literature on this. But this is what I do, and I have not yet come across. Again, that's anecdotal, but this is what my patients do.
May I ask you again, what is the dose you use for vaginal estrogens? Any idea that you can give us? Or a frequency of dosing?
0.1%, I think I'll have to look that up. And the applicator has got that, which will deliver just that dose. 0.5, okay, whatever. Yeah.
And you would give it how many times a week?
That's what I'm saying. So in the beginning, it'll be daily for a month. Then alternate days. For the first 3 months, it's quite frequent. After that, you slowly should come down after 6 months to about once in a month. So you write it down. I have one schedule, and I get confused about it myself. So, but it doesn't really matter. So long as you're giving it high dose in the beginning, almost daily, but in the second, third month, you're making it bi-weekly, then once in 2 weeks, then once in a week, then once in 2 weeks, and once in 3 weeks, like that. And at the end, you'll be giving only once in a month. And then after 1 year, say, okay, give it a break. And if you get any symptoms, restart it. Just.
We'll go to the next two, but before that, any questions on the topics discussed so far? Yes, sir. Now we spoke about not giving new statin in a 75 plus person. In a person who's had angioplasty done before the age of 75 and still on statin, do you continue statin or you discontinue statin? Yeah.
Hello.
That was the commentary that they started.
Okay, okay. So yes, so the answer there is a little difficult because generally we do continue it because it's not now a primary prophylaxis, okay? It is prophylaxis, secondary prophylaxis, and the fear is that the plaque which this person may have still there could somehow get activated and rupture by your withdrawal of statin. So I'm very scared to do that. But
Yes.
sometimes there are 90-year-olds and he's on his deathbed almost, you know. What harm is there? Yes, yes, if you have, there are many people who usually have problems, you know, like some mild aches and pains, you don't know what it is and all, then you can give it on alternate days.
Statins, yeah. She's asking if there's any pharmacotherapy for menopause other than estrogens.
Well, you know, there are all these non-pharmacological things like soya, which contains plant estrogens. And then there are some other things also. What are they in the West? Phytoestrogens, that is your soya. So they say, but I don't think they're that effective, but it's a non-pharmacological. So
In pharmacology, the one drug that I know is Kumar will corroborate. Paroxetine, 12.5 milligram,
oh,
has been approved for by US FDA, has been approved for menopausal symptoms, especially hot flashes.
Oh, okay. I learned that today. Thank you.
Somebody wanted to ask a
But
question
that's
there.
the drug paroxetine, which is
SSRI.
the worst of the SSRIs. No, it's the worst of the SSRIs,
Yeah,
isn't
it
it?
causes the maximum weight gain.
Maximum, yeah.
Weight gain amongst the SSRIs. For how many years after menopause?
Anytime after menopause, but interestingly, and I don't know what's the answer to that, menopause maybe have happened at 50, but the symptoms will come on at 75. So I think it takes that time. There is still a little bit of estrogen coming out from the adrenals, and you know, the other thing is they say if you have a lot of fat, the estrogen, whatever little is being produced, is deposited in the fat. So I'm very happy about that part of it. So
Dr. Vivagar,
yes, no prophylaxis.
I'll repeat. He's asking in a person who took HRT when HRT was kind of at the rage, and now she is 70. The patient took HRT for, say, 5 years. At the age of 40, do we do any monitoring at the age of 70 for side effects of HRT?
No, basically we're looking at cancer and deep vein thrombosis. No, once they've stopped it, the vulnerability goes down pretty fast.
Yeah, Dr. Lopa. She's asking about contraindications to vaginal estrogen in patients with atrophic vaginitis. Any precaution to be taken?
See, they used to say that if even any malignancy in the breast also, certainly no systemic estrogens, but I've heard some people talk about vaginal estrogen, but then I've also heard that it's quite okay. I think it's quite okay. So there are no real contraindications.
Yeah, doctor, you want to ask? She's asking if somebody was started at a young age, say 30, 35, 40, because of a very strong family history and high LDL, and now the patient has survived somehow till the age of 75, and the LDL is still high.
There you must continue.
Basically, the patient has survived because of the statin. Is
Yeah,
it?
there you must continue.
Yes, sir. What do you do for menopausal women or perimenopausal women, prevention of osteoporosis or osteopenia? What are the methods that we can
One
use?
important thing is, the recommendation is after the age of 65, every woman must have a bone mineral density done. DEXA scan is the most.
65.
65. Not at menopause unless they have an indication like they, of course, if they've had a fracture, then they've already got osteoporosis, a fragility fracture. But if they are okay, they don't want you to do the BMD too early. They want you to do it at 65 because research shows that that's when, because not everybody is going to get osteoporosis. That's when is the maximum chance that osteopenia will become osteoporosis. So for some reason it's 65. But you might, if there's a strong family history, might, and of course, if you've got a Caucasian patient, they are most vulnerable, then you might want to do it earlier, but the recommendations say 65. So if there's osteopenia, that means it's above minus 2.5. Now, I've known one doctor who, for one of my family thing, it was minus 2.4, and so said, it's not minus 2.5, so you're okay. I mean, he should have started her, and she developed a fracture the following year. He says minus 2.4. So, but the cutoff limit is given. So if it's 0 to minus 2.4, technically, they osteopenia. They must have good calcium and vitamin D. Whether they are deficient or not deficient, they should have it. The understanding is that vitamin D is, of course, supposed to be one of those wonder vitamins which cures everything from tuberculosis to heart disease to everything, and also improves muscle strength, and it has been shown to prevent falls. Okay, they say the study is flawed, but it does prevent the bone, as we grow older, the dynamic equilibrium of bone deposition and bone resorption, which is perfectly matched. In the elderly, it is not. So bone resorption is a little bit more than bone deposition. So everybody, and then when the estrogen goes off, it's catastrophic decline. So yeah, you do need to give vitamin D and calcium to slow down that resorption thing a bit more. But please, people are not looking at osteoporosis. They are not giving the bisphosphonates. They're waiting for people to get fragility fracture. Once a patient has a fragility fracture, don't do the bone density, please. Just give it.
May I ask you about your take on bisphosphonates versus the newer drugs that have come?
The bisphosphonates are the time-tested ones. I agree. There's so much of hype about this upper GI business, and be standing and take water, and I've never come across a single person, but for legal purposes, I make sure that that is written in black and white, and I have taken many patients through weekly alendronate, which is the lowest of the lot. Ibandronate is monthly. It all works out at the same cost. And so all the bisphosphonates, I have great faith in them. There was only one lady, but again, because I don't have records, I don't know, one lady, frail, the perfect person to get a fragility fracture, started on alendronate. 2 years she had it. The 3rd year she fell and broke neck of humerus. So she came and thanked me and said, I might have had neck of femur, but because of your drug, I only got humerus. So, which is not really true, but I also believe in it. So I believe in bisphosphonates. What I don't believe in is the use of teriparatide.
Rampant use.
And this is a pure example of, to me, pharma. It's so expensive, and orthopedic surgeons love it, and they have one advantage. You cannot give bisphosphonates after a fracture or after a surgery for a fracture because it prevents the bone deposition process, you see. So, and that's why we say if you've got to have a dental surgery, please finish that off, then start the bisphosphonate. If you're already on a bisphosphonate and you have to have tooth implants or something, you must go off the bisphosphonate for 3 months, let your bones soften up during those 3 months, then you do this, otherwise you'll get osteonecrosis of the jaw. Because the bones actually become brittle and they fracture. In fact, when you're on alendronate, the subtrochanteric fracture can occur due to that. So it's a dicey thing, but teriparatide is one drug, it's a parathormone analog. You can give it immediately after the fracture. It does not harm the callus formation, does not hamper callus formation. However, its expense is phenomenal, 15,000 a month, and bone pains and other side effects are there. And when I asked my classmate who runs a top-notch orthopedic hospital in Coimbatore, 2 kilometers from where I am, I said, David, why do you guys talk about osteoporosis in your conferences? He said, why should we? We shouldn't, because we won't get any. So orthopedic, but they love this drug because it can be given. The other thing which I like to give is nasal calcitonin. Immediately after a hip fracture, you can't give it for a long time, only 2 months, and it does help with the pain. So when I was working, I insisted with my junior orthopedic colleague whom I could force him to do things. He didn't want to. I have to see every hip fracture. He said, no, but you'll take away my fees. Patient will have to pay you also. So I said, okay, you pay me only half the fees. Because hip fracture actually should be managed by a geriatrician, and the orthopedic consultant is only a technical plumber in that episode. Everything else around the hip fracture is in the purview of a geriatrician. This is where we need specialist geriatricians. Because the pain, what caused the fall in the first place, is the thing to look for, because he's going to go out of the hospital and fall again. Okay? So these are things they don't talk about. So yeah, many hospitals overseas have an orthogeriatric sub-department. Where the geriatrician manages everything, orthopedic person just comes and does the surgery and goes away. So the whole thing about anticoagulation during the geriatric surgery, during the hip surgery, they refuse to give it. I have to force them to give it. Sometimes they come out from the operation theatre before going in, and I pull them out and say, delay the surgery for 12 hours while I start off the anticoagulant. Because they're scared. All surgeons are scared of anticoagulant. I feel for them, because I'm not the one doing the surgery. They're the one who got to face the bleeding. So, these are all very complicated issues in an elderly person. So many elderly people die of pulmonary embolism post-surgery, and nobody bothers about it. But having been in hospital practice for elderly for the last 7 or 8 years, I have seen enough of it to know that this recommendation of giving anticoagulants is a very good one in elderly.
Also, there is now a statistic which says that hip fracture reduces lifespan. Is that true?
Yes. Oh, yeah. Yes. Even if you don't correct the hip fracture, of course, don't operate, it will die very quickly. The immobile pressure sore, perfect. Even if you correct it, the lifespan is shortened. I'm not sure by how many years, but the mobility never comes back to normal. Some people do get away, but the majority of them don't. It's also because our physio, our aftercare, especially in India, is abysmal. We have, Coimbatore is a place for orthopedics. People from big orthopedic hospitals in Chennai come to Coimbatore for opinion and get operated here. We've got standalone orthopedic hospitals. Even they will operate on the person, send the person home. After 1 month, the dinner plate size of ulcer would come to me. Dinner plate size. So I used to talk to them and say, what are you all doing, So I haven't sorted out the problem. We have to have teams, So, yeah, hip fracture, pressure sores, these are all very big topics in hospital medicine. So the most important thing is prevent it, look for osteoporosis. What I saw in the UK, I was just fascinated. I went with the physiotherapists and occupational therapists. They have home visits for every patient who falls. Because the state is paying for it. They have to prevent the next fall. So they go to the homes, they ransack all the rooms, whip out all the carpets, raise all the chairs, make the bath more friendly, and guardrails, what all, because most of them fall down the steps, and you won't believe it, on the fair skin, looks like they're tattooed from top to bottom, so much, as they roll down the stairs. And so the house is made safe. So we have to prevent falls at all costs. So it's not just looking at their propensity to fall, but the environment, lighting, staircase, handrails, making them use assistive devices. This is the most difficult thing. I thought it's only Indians, but it's all over the world. No older person, if I ask any of you to kindly use a stick and walk, you will just outright refuse me, okay? Because it's a stigma. We have to get over the stigma, and I envisage a day when our pavements will be so friendly for elderly people. Everybody will be having a stick and a walker and walking happily, because elderly people need that extra support. You can't afford to have a fall. So please promote assistive devices in your patients, and always have I don't know how many of you have the advantage of a physiotherapist easily available for elderly persons. Don't just give them the stick. They have to learn how to walk with the stick, which hand to use the stick, how to use it. And once you have given them the stick, in the next visit, if they come without the stick, Yes, yes. So once I sent a patient, I said, please madam, use it outside, because they said it's in the boot of the car. So the younger person went, got the stick, and when she entered, I took a video of her as she was in, just to make the point, not to humiliate her or anything like that, just to make the point that there's nothing wrong in having an assistive device. It's very important.
So having said that, we will be sending you some pictures of assistive devices that are available in Mumbai with their costs and everything. And I think we should be promoting that more and more. Yeah, doctor. Another drug that is used for osteoporosis currently is denosumab. Do you have an opinion?
I think it's a very good monoclonal antibody to be given, and it's very expensive again, I think 16,000. But it's superior to even zoledronic acid. Zoledronic acid is once in a year. I hesitate to give that, but because you can't just give it in your clinic. I think you have to. They do say to come and be in the casualty, but if you can look after them, they have some bad reactions, not fatal reactions, but some difficult reactions. So yeah, it's much better. I have no experience with it, but I understand that it's quite good.
We go to the next, immobility. Immobility, just one thing that they would love to know is about prevention of bed sores. Give them some tips on how to prevent bed sores.
Yeah. But of course, bed sore would happen in somebody who's totally immobile, cannot turn, say after a stroke and things like that. But other forms of immobility, minor forms, are in people who that you'll be surprised, but there are many people, and you just ask them the history. What do you do all day? This is one gimmick I employ when I'm not able to understand what the patient has. They're complaining of this, that, and all kinds of things. So I say, okay, tell me from the moment you get up in the morning to the moment you go to sleep, what do you do all day? And they'll say, I have breakfast, then I do something, then I do the puja, and then I have my bath, and then I lie down. By then it's 10:30, and they keep lying down till they have their lunch. And what do you do after lunch? Then I have my after lunch sleep. And so they're actually sleeping all day. So I say, now what about going for a walk? They've never heard the word, and they say, I'm scared, there are dogs all over, and cars are coming, and people live in such surroundings that they cannot go for a walk. But I tell the relatives, you have to find the time, and you have to, because fear of falling is a big thing. So basically what I'm saying is, immobility, not to the degree of pressure sore, but just sitting around. One person tells me, I do the cooking and I cut the vegetables. I said, that's not exercise. Exercise means a regular contraction of the muscles at a particular pace. I said, look at me. I'm sitting and seeing patients for 8 hours. It's not exercise. I'm not exercising my muscles, I'm exercising my brain. So that distinction between work and exercise is very important, and they must have aerobic exercise, to be limited in those who have cardiovascular and respiratory disease, no doubt. But if they have those, then programmed with the physiotherapist to see how the oxygen saturation is when that's required. But for the average elderly person, yes. And you must have a leaflet. I don't know whether you have it. I have a leaflet which I've just taken off the net. I give to every patient who is like wheelchair bound or can get up and go around somewhat. So there is a set of exercises they must do to keep the conditioning of the muscles. If the muscles are deconditioned, they just melt away faster, and number two, muscle cramps will come. So what you have to do, there's simple exercises. For every muscle group, abductors, then like this, rotators, then for the hip flexors, extensors, stand up, hold the chair and just extend your leg, or bend, very simple exercises. Please do them for 5 minutes every day, 3 times a day before your meals, not after your meals. And so you get that into program. Nobody does it. But if they do even once a day, it exercises all the muscles they contract. So some form of regular exercise has to be done, and the family members have to help them, motivate them, whatever. So deconditioning of muscles is a very important issue, and falls happen because of that. And when it comes to pressure sore, if you are caring for bed-bound elderly people, in the hospital it's extremely common, and that's all because of poor nursing care. I only blame the nurses for it. Because when I started off as a junior lecturer in CMC, I have seen the worst bed sores ever known to man. I have seen the head from the trochanter, the trochanter come. I mean, I could see the trochanter. And then finally, I have seen the most miserable. By the time I retired, I never saw a bed sore. Okay? Partly because the patients were also better. I never saw a bed sore. Because the nursing protocols had become so excellent, there was an hourly turning of the patient. You can have air bed, water bed, alpha bed, whatever you say, but you still have to turn the patient. You still have to turn the patient. And it's right through the night. And then you know how to maintain that position. So now in every nursing thing, at least in GKNM hospital, we had right side, left side, oblique decubitus, supine, prone, everything was there, all nicely ticked off, never done. Okay? It was just ticked off. So, one had to go there and say, okay, if you turn the patient, where are the pillows? Oh, there are no pillows. Obviously, you haven't done it. So you see, point I'm trying to make is, you put in any rule, you also have to make sure that it's followed and not just written. And it's a laborious process. But once you get the hang of it, it's fun. I have gone home visiting and seen the most awful pressure sores. And there is no need to have them, but it is not easy till somebody finds out a better way of this. But alphabets do help.
So important message here is the prevention is hourly turning of the patient into various positions. Airbed laga diya aur fir kuch nahi kiya has no meaning. You have to turn the patient. So family has to be involved at home.
Yeah. And there's this thing about, there's something the sisters used to tell me in Coimbatore, Wasa Musa. So what is Wasa Musa? It sounds very interesting. So it's some kind of a gel which they used to put on the patient and say, oh, Wasa Musa laga diya, now ella nalla irukuduma, don't worry and all that. But that's all rubbish. There is something to do with nutrition. Good nutrition. They say pressure sore is one way that you detect the NABH, NABH, no? One of the ways they test is how many pressure sores you've got. So we had a pressure sore website where you had to put it all in. And nutrition, it's a multi-dimensional, multidisciplinary approach. The nutritionist has to come in. Unless you have good, healthy tissues, you will get. In the UK, in the hospital that I work, they have something called the tissue viability nurse. They also had the, we used to call her the incontinence nurse, but she said, I'm the continent nurse. Okay. So these are this role of elder care was given to the nurses who are better, and they went around the whole hospital and whether they were called or not, and they had to check every patient's continence, they had to check every patient's skin or the sacral region or the thing, whether it was okay or not. So it needs that kind of a thing. Only nurses can do it, again with dietitians, then surgeon has to be involved, and finally it's the doctor who is responsible if there is a thing. So it's a hard business, but it's something when we got our degrees, that is something we signed up for, so it is our duty.
The last topic of the day, I realized that we are now only 15 minutes away. So the last topic of the day is the cognition part, dementia, delirium, both. She was keen to talk about delirium in the elderly because it's also a treatable problem. So tell us about delirium.
So just before that, can we just talk about memory? Sure. Because everybody loses memory as we grow old, and the fear is that we're going to have dementia. So there is a normal memory impairment, and there is a dementia. We're not going to talk about types of dementia. But in between, there's something called MCI. Mild cognitive impairment. Okay, that MCI in me does not allow me to say mild cognitive impairment. Now with the help of my friend here, yeah, MCI. So in MCI, how do you differentiate? So the example that I give is, many people, they're so worried, they say, doctor, I just can't remember anything, you know. I'm also worried, I can't, where to leave the keys, this, that, and the other, and I was so good at recalling this, that, and all. So the dictum is, which is not 100% dictum, if you're worried about dementia, you don't have it. If you have dementia, you're in blissful ignorance. You don't know that you don't know. But we are talking about advanced stages, okay? So the guy goes into the shop and he says, oh my God, I didn't bring my list. My wife sent me to buy this, and he rings up his wife and she scolds him, said, just asked you to buy 5 things and you still don't remember it and buy them. Whereas the guy with dementia will go and say, what is this lovely place that I've come to and all that and this thing, and he gets into his car, takes 1 hour to get back because he's forgotten the way to the house. So he's dementia, and the other one is normal memory loss. So, but still, anybody who's worried about it, and even anybody who's not worried about it, all patients above the age of 60 must have a screening test. And I think you all know that there are many hundreds of screening tests. Just get familiar with one of them, which is fast to administer. I find the mini-cog is a very fast thing to administer. So basically you give them 3 unconnected words to remember. Keep it in your mind, make sure they understand it, repeat it after you, then do something else, check their blood pressure or something, and then remember, you have to remember to ask them. One patient keeps coming in, and every time I say, what's wrong with you? He said, chair, ball, pen. Because that's the question he knows he'll be asked. And another patient told me, doctor, you forgot to ask me. Okay, so aside from all of that, so mini-cog, if they recall all 3, they passed. If they recall 2 out of 3 or 1 out, if they recall none, they are obviously got problem. 1 out of 3 or 3 out of 3, then you must do the clock drawing test, okay? And I don't know how this clock drawing test is not something which all Indians can do. If they've never been interested, never coming for seminars, never called by Tushar, didn't have this thing. The person in the village only wants to know, is it morning or night? That's all they want to know. They've never seen a clock. So I'm just taking extremes, but for average urban practice, a clock is all right. But after this generation, this millennial generation, they don't look at the clock. They just have digital. So we'll have to change all that. So once the screening test is normal, no have to proceed. If it's abnormal, then you must do the other important tests. And people all over the world, according to the literacy standards and all that, have come up with other types of tests. The test called MMSC is useless for our Indian population, but because we don't have a better test, we do it. So there is a group in India who's trying to do for the rural what test to use, this thing. Then we use translation. So basically, if on the MMSC you have a poor score, then you say, okay, this is definitely dementia. But delirium also can give rise to a lower score. So when we say dementia, it has to be there for more than 3 months and 6 months, and it has to deteriorate. Whereas delirium, you will score badly, but it may come back to normal. So we're not talking about that, but you actually asked me to talk about delirium. So delirium is something which every general practitioner should know something about and should be able to smell it and diagnose it, because it needs treatment, it is treatable. So how it's different is, there is a global cerebral dysfunction in delirium. And usually what will happen is, if there are two main types, an agitated delirium and a quiet delirium. If it's a quiet delirium, you may miss it. The person is just sitting there not saying anything, okay? He may be just a laconic, shy kind of a person, but you could miss it. Whereas the one which agitated, hallucinating, seeing donkeys here and something there, very easy to diagnose. Their behavior is abnormal, their attention span is low. You try to ask them, so what happened yesterday and all that. So, in 1948, something, then he stops talking. He's not answering your questions, poor attention span. So, he may be looking otherwise normal. So, there are many of these things, and then you'll find a fluctuation in the sensorium. Certain part of the day they'll be all right, and especially at night, even in dementia, there's a sundowning effect. At night, they become agitated, misbehaving, doing all kinds of things. So morning time, they're normal. So this sleep-wake cycle also will be reversed. They will sleep during the day, be awake at night. So many of these things may tell us that the person has, and they'll be disoriented. You just check a person who's otherwise well and say, so what is the date today? And he'll say, it is 10th or 12th, it'll be all wrong. What day is it today? I know it is, but I don't. So they'll be talking to you like this, but I'll be totally disorientated. And one person, I went to the house to visit, and I said, so who is this person standing in front of you? That person got so annoyed with my question. Why are you asking that? She knows I'm Padma. So she said, Padma dana. I said, wait. Then I got another person and said, who is this? She couldn't answer. So this person was suddenly very angry. How? She knows me. So you see, the family member also may not be able to recognize. Now, the question why they had called me was, she goes in the night to the bathroom, fills it up with water and sits in the bucket. So she was actually dementia, but it had happened suddenly. So it was a delirium superimposed in dementia, which is very difficult to diagnose. So anyway, what I'm saying is, these are the things: fluctuation, it can be agitated with hallucinations, disorientation in time, space and person, inattention. Normal person, older person will be able to carry on a decent conversation with you, whereas a person with dementia. So that is one. There are various scales also, abbreviated mini-mental and all those things. I saw in the UK, they were so good at it, just like they take the blood pressure. They'll be saying, okay, Mr. So-and-so, so what time of the day is it and all that. As part of the examination, they said he's got 4 on 10. He's got delirium. They were so good at it, I could never come to that level. So somebody has to do that. And then in the casualty, in the emergency, there's another way of doing it. We won't go into all those details, confusion assessment score. Those who are interested, or when we are studying these things in detail, we can look at all those things. So why is delirium so important? Because a person in delirium has a higher mortality. So after hip surgery, if somebody goes into delirium, his mortality is higher. So you have to treat it. There is no treatment for delirium. We only have to find out what precipitated it. So if you know the precipitating factor, remove the precipitating factors. So the precipitating factors are any new drug, like we just said, diuretics and all those things. Any new drug added, any infection, okay? So you can see how infection actually affects most of these. So any infection can give rise to delirium. Any new drug, we already said. And then electrolyte abnormalities. So a delirious person, hyponatremia is the most important one of them. Then certain cerebrovascular diseases, for example, like a small stroke, good. And if the stroke has produced a hemiplegia, then it's very easy. But small subcortical infarcts can happen in these patients. For that moment, for 3-4 days, they are very unwell. There are no deficits that you can pick up even if you're a good neurologist. You can't be doing MRI scans for everybody, you see. So these are the causes of delirium. So everybody must have electrolyte done, especially if it's an acute delirium, and then you have to correct that. And as far as possible, you have to support the patient by making sure that they come back to orientation. So if they don't have their glasses, if especially they get admitted into hospital, you see withdrawal of benzodiazepine, they get into hospital, and then so we say, where's the specs? Go get the specs. They must wear the specs. Put a calendar. Iniki tingal kalam irukku. Today is Monday. Yesterday was, and you quiz them. So you train them again, make them hear, keep talking to them, explaining nutrition, all those things, hydration. And so that's the treatment for delirium. If they come out of it, it's fine. Most of the time what happens is when they have agitated delirium in the hospital, because the neurologists will be called, they'll be put into an MRI machine and they'll get more delirious, start shouting, this, that and the other. So I've had instances of pulling them out of the MRI machine. I've had people ringing up from America and saying, madam, we can afford MRI. Why you stopped the MRI? I said, because he got a urinary tract infection and he developed abnormal behavior. Please don't do an MRI. So these are the kind of things we have to battle with. And then when they're very agitated, you do have to give them drugs. So the drug that is given is benzodiazepine. Benzodiazepine causes more delirium.
Like we give in alcohol withdrawal, delirium, same.
Yeah. There it's all right. There we give chlordiazepoxide, but even benzodiazepines have been allowed, but because of the addictive potential of benzodiazepines, and already a person is addicted to something, they've got that, we try not to use benzodiazepine, at least I didn't. We used to use chlordiazepoxide, which is again a benzodiazepine in a way, but doesn't cause addiction so much. So for agitation, you may have to. So what we try to give for these people is haloperidol. Haloperidol, if they are very agitated. Now I had one patient who was going to beat us all up. We ran out of the room and we had to call a male person who immobilized him from the back. And I told the sister, quickly get the haloperidol ready. I'm not going to come in. The assistant held him from the back. The nurse jabbed in 5 milligrams of haloperidol. He slumped like this, we put him in the bed. Then you have to maintain it. So most of the patients are not going to be so bad. So 0.25 milligrams of haloperidol or Serenase, what you call, 0.25 to be given once or twice, knowing that haloperidol is going to give rise to extrapyramidal syndrome and is going to become stiff after some time. So you have to give very, very low doses, don't give in a regular dose. Risperidone also for agitation, they say is okay, 1 milligram better than this, but you have to watch out for the extrapyramidal syndrome. So just agitation. These are the things we also give for patients, antipsychotics, which we also give for patients who are having behavioral and psychological disturbances or behaviors in dementia, quetiapine, other psychotropics we use. But in elderly, they say the least amount of antipsychotics is best. Mortality is higher. Give it for the moment. Try to withdraw as fast as possible. Unless, of course, they've got a psychosis, full-blown psychosis for which they might have been on valproate or something for many years. Try not to give these antipsychotics. So the neurologists and all will give them maximum doses of benzodiazepine. We try to work with them and withdraw them. So
one important takeaway from here is that in a patient who's acutely delirious, very violent, then the dose she mentioned, 5 milligrams, not 0.25 for that. 5 milligrams for the acute episode,
for the injection.
Intramuscular injection
dose is higher.
Whereas the oral maintenance dose, what she said for a few days, was the lower dose of 0.25 milligram tablet. So we should not confuse doses there. If you want to give haloperidol, haloperidol of course is Serenase, that you all know.
You can give 2.5 if you want injection. Injection is always higher. Which unlike other drugs, usually the oral is higher. This is the other way around.
I think we'll end here and what can I say? Thank you so much for coming. She's come from Coimbatore only for this. There's no other reason for her to come here. We found some reasons, but otherwise this was the only indication for her coming. And I'm so grateful that you came. I'm really grateful.
Somebody offers to pay you airfare, put you up in a nice boutique hotel and this thing. How can you refuse? Sorry?
Ahmedabad is closer to Mumbai, and he said,
Why did you come here?
Why
Because
did
I
you?
hate cricket. Thank you all
Thank you
so
so much. Big round of applause again for her. Thank you so much.
I've enjoyed being here because of your reaction.